This is fantastic from all over Nigeria. Bayer Pharmaceuticals is also joining us, co-sponsoring this to just try kind of also talk about a few other things. All right, so straight away I'll go on. I think we have a good number. My name is Dr. Iseko. I'm a physician cardiologist with Cardiocare Hospital. Cardiocare Specialty Hospital is a member of Limi Hospital Group. It's located in Abuja, and the webinar series is an initiative of Cardiocare to kind of make sure that everybody, that we share part of our knowledge, part of what we have learned over the years with the medical community. We believe that by teaching and by exchanging ideas with other doctors, that Nigerian healthcare can get better. So essentially this webinar is essentially targeted at doctors and maybe any other allied healthcare professionals, you know, cardiac nurses, some nurses, but primarily targeted at doctors. So it's going to be a doctor level in case somebody has joined up as a patient, maybe saw one of the ads and decided to join up. You may not get much from this presentation because it's not directed at patients. I see quite a number of professors and cardiologists have also joined up, and so we'll have a very nice time today. So I bring you from Cardiocare, as I said. This is what Cardiocare looks like here in Abuja. Endocrinology, nephrology, and oncology, intensive health, we have it globally. So that's especially by the US as the most common preventable cause of death among hospitalized patients. It's the kind of one that patient is doing.
Okay, so I think we're having some network issues there. Hopefully we're going to get that back online now. Okay. We thank you all for attending this webinar. And this afternoon, again, we're talking about pulmonary embolism, as had been earlier introduced. And he mentioned earlier that it's usually a shocking thing when a patient dies of pulmonary embolism. I'm sure that we've all witnessed previous different scenarios in the past in which a patient that appears either to be doing well before or that has some other conditions that we are aware of, and then the patient just sustains a pulmonary embolism, and that changes the clinical course of the patient, basically. So we need to look, this afternoon, we're trying to look into the best ways to recognize that and the things that can be done to, you know, for either forestall this or prevent this kind of occurrence from happening in such patients who have such an episode. Of course, pulmonary embolism is a game of risk factors, like is shown on this Dr. Iseko's second slide. Okay, I think it's back online now.
Okay, so I will just continue. I think my slide is back up. Sorry for the break in transmission. It's Nigerian internet. Connection. So I want to change my internet connection.
Okay, while you change your internet connection, I will.
And that's what I'm going to be using for this presentation. Sorry. And in the US, most of the insurance companies have decided that they will not pay for deaths or pay for care that related to pulmonary embolism. And that includes PE or DVT. And so that tells you that it is something that hospitals are supposed to take care of a little bit better. Dr. Officer, in case my internet goes up, you have to continue as usual. Okay. And then Dr. Alelekontu can also continue. And so, but the way it presents, it makes the diagnosis of PE quite difficult because of the clinic, the way it has been presenting, you know, is quite a masquerader. One of the main challenges is when to suspect pulmonary embolism. The majority of patients with PE die because of a failure on diagnosis rather than inadequate therapy. And this is from the ESC, European Society of Cardiology. Mortality rate is approximately 30% in PE, and whereas when without treatment, whereas when with treatment, the mortality rate drops significantly. So that tells you that identifying and making a good diagnosis and giving treatment goes a long way to helping reduce the rate of mortality. However, the problem is identifying it and keeping up that index of suspicion. Okay, some people are having difficulty joining up. Unfortunately, we have not been able to stream on Facebook as we had. So in case you have anybody, tell them to just use the link. There's a link in their mail, and they can use that. They can join up with somebody else as well. So I'll just continue. So epidemiologically, and I will quote foreign studies for now, and then I will now quote Nigerian studies. PE is said to be the third most frequent acute cardiovascular syndrome, only after MI and stroke. And so PE is considered a cardiovascular disease, and it is the the third leading cause of death after MI and stroke, with incidence rates for PE of 39 to 115 per 100,000 population and DVT of 53 to 162. It's important to state at this point that PE and DVT are kind of two different diseases along the same spectrum, okay? And it is estimated to cause around 300,000 deaths per year in the US. Okay, so I'll come to Nigeria a little later to try and explain the Nigerian situation, okay? Okay, so, there was a study in 2004 across 6 European countries. 370,000 deaths were related to venous thromboembolism. 34% were said to have died suddenly or within hours of the acute event before therapy could be initiated or take effect. So that is, the patient came in with pneumonia, we started treating, everybody is saying, if I'm not okay, we'll discharge him tomorrow morning, and he suddenly died. Or patient with stroke, then suddenly died. Those kind of things. Patient was fine, and then suddenly died. Patient came in for a CS or myomectomy or a different thing altogether. And then after 3 days of admission and died. So those are the issues we're talking about. It's also, children are not spared, and in children, while the incidence is much less than adults, it still happens, and it's something to also think about. Only about 7% of patients who died in this study were correctly diagnosed as PE before death. And you can see that shows that even in Europe, there is a large diagnostic gap for PE. So, and most of them were diagnosed after death. In UCH, Awotedo et al. Did a study over a 5-year period ending in 1989, from 1984 to 1989. And what they found was that there was a 3.8% prevalence of PE among the autopsies they reviewed, and only 15% were diagnosed before they died as having PE. That is even better than the European figure. So that means our diagnosis was a little bit higher. Shotunbi et al. Reported mortality rates of 11%, and in Skemi Badon, Adelaya also, neurosurgeon, reported a mortality rate of 60% among post-operative PE patients with a DVT incidence of 2.4%. So you can see that this happens across all specialties. It's not an internal medicine specialty or a specialty for one other group of people. It's a specialty for all doctors. So now I'll go into the pathogenesis. In case you have any problems hearing me or anything, please just indicate in the chat box, so I'll make some adjustments. And if you have questions, please put them in the question and answer box, So that some of them I will answer them as I'm explaining pathogenesis. It's extremely critical now that you pay attention in the pathogenesis, because once you understand the pathogenesis, you've understood it. And if you don't understand the pathogenesis well, it will be very difficult for you to carry on with the PE, with the understanding of pulmonary embolism as a whole. Okay, so what is the pathogenesis like? Pathogenesis essentially still dates back to Virchow, and Virchow's triad still forms the best framework, a conceptual framework for understanding the pathogenesis of venous thrombolism. Now, what does that Virchow's triad essentially entail? It entails a combination of three things that happen essentially to increase the likelihood of a venous thromboembolism. The first thing that could happen is stasis, and stasis stasis of blood or slow-moving blood that could happen in different conditions, that could happen with lung immobilization. All that could all be part of it. The next thing that could happen is hypercoagulability, which could be either inherited or acquired hypercoagulability. We'll talk about that going forward. And then injuries to the vessel wall, which will now trigger the coagulation cascade. So what are the predisposing factors? The inherited factors, which are hypercoagulable states, include these ones. They are sometimes quite expensive to diagnose, but if you see any patient coming with recurrent episodes of thromboembolic phenomena, it is very important that this thrombophilic panel is run. And we're looking for factor V Leading, prothrombin G mutation, that's the 2210A mutation, deficiencies in protein C, protein S, antithrombin. All of those will lead to more because they are supposed to balance protein C, protein S, and thrombin are supposed to balance out thrombus formation to make sure that there are no excesses of thrombus formation. And then hyperhomocystinemia. In hyperhomocystinemia, the effective treatment is giving folic acid. So folic acid in these cases, there are a lot of studies that have been done about hyperhomocystinemia as a novel risk factor, cardiovascular risk factor in stroke. A lot was done when back here, even here in Nigeria. However, most of the studies show that even treating hyperhomocystinemia does not significantly change the risk factors going forward. And then elevated factor VIII levels. Now, there are so many other acquired risk factors and other risk factors that could predispose one to pulmonary embolism. A doctor must keep this at the back of their mind while treating the patient so that they know that they must, without a doubt, start anticoagulation in some form or manner. And so what are those risk factors? The odds ratio of greater than 10, these are the ones that have an odds ratio of greater than 10, and that means that they are very strong risk factors. Fracture of the lower limb, hospitalization for heart failure or for atrial dysrhythmias, hip or knee replacement, major trauma, MI within the past 3 months, anybody with previous DVT or people with spinal cord injury. Once you have patients with this, it's almost invariable that they are going to develop some form of DVT, either in the lower limbs or in the pelvic vessels. And then we have all these other ones which are moderate risk factors with an odds ratio of between 2 and 9. Chemotherapy, heart failure, blood transfusion, one patient has a central venous line, and those central venous lines are particularly important in children. So those are the things that will play a role in children. People going on IVF, and this is where the gynecologists will come in, and oral contraceptive therapy. Virtually all forms of oral contraceptive therapy increase the risk of thromboembolism, although some are more than others, depending on their estrogen, progesterone content. In the postpartum period, similarly, even during an infection, stroke, and when there's a superficial venous thrombosis. Then there are weak risk factors. Diabetes is considered a risk factor and is weak, but when a patient comes in with diabetes and an acute illness, so that will mean that if they come with a hyperglycemic state, just diabetes alone may be weak, but when diabetes combines with an infection like pneumonia, combines with stroke, with MI, then the odds ratio shoots through the roof. And then people after surgery or even during pregnancy. So in children, PE is usually associated with DVT, and it really just happens. Typically, they will have had a central venous line, like I said earlier, or they have very serious chronic medical condition. But the doctor must keep it at the back of their mind to prevent death and to improve quality of life. And like I said, it is a part of the cardiovascular disease continuum with common risk factors. The risk factors spread across both diabetes, hypertension, heart attack, cigarette smoking, obesity, cholesterol, all of that all play a role. And without prophylaxis, DVT in the hospital is acquired DVT is 10 to 20% among the medical patients, and 15 to 20%, 40% among surgical patients. So you can imagine as much as 4 in 10 surgical patients will develop a DVT without prophylaxis, and this is why prophylactic measures will be taken. Now let's go straight into the pathophysiology without wasting time. Okay, I think we have quite a number. We have over 130 participants now. So what does the pathophysiology work? The pulmonary embolism essentially presents through, acutely, it presents through one of 3 syndromes. Chronically, it can come about, it can show up just as chronic thromboembolic pulmonary hypertension, in which case the person just has breathlessness as a long-term sequelae. We see a number of patients with this in Cardiocare, where they come with features of people are wondering whether they have heart failure, they're having some edema here and there, but essentially they have almost a normal, good left ventricular function, not much diastolic dysfunction. They have some, but then we see quite a markedly elevated pulmonary pressure. And we can also go straight into our cath lab and we'll measure that pressure. And so we see a lot of patients coming with chronic. They were not diagnosed acutely, but chronically they now come in with pulmonary hypertension. Very debilitating, very difficult to treat, but it's something that we must keep at the back of our mind as a differential for heart failure or for breathlessness, even in the COVID era. Now, 3 syndromes can come about. Number 1, an acute cor pulmonale. So a patient comes with sudden development of difficulty in breathing. Patient was fine and is suddenly breathless with cyanosis, with shock, unrecordable blood pressure. Patient referred to us recently had sudden onset cardiovascular collapse, cardiogenic shock. SpO2 was very low, BP and pulse not recordable, and then was managed and sent to us straight away. We took straight to the cath lab because troponin was also elevated. The vessels were clean, the D-dimer was out of the roof, and we managed essentially by giving anticoagulation and other things, and everything came down. We also had patients where we had to give thrombolysis to help, and that really changed the massive P. I also discussed some other cases further down the line. The second syndrome that presents in this form essentially is pulmonary infarction. So what happens is that there's a blood clot in the pulmonary circulation. The right heart is pumping through the pulmonary vessels into the lungs, and is now pumping against a blocked vessel. So what then happens? That pressure is transmitted back. The right heart has to dilate, now goes into failure, and then it now causes, blood is not being able to transmit properly to the right atrium, to the right ventricle, going around, and then you now have some cardiovascular compromise happening there. You also have dyspnea as one of the major presenting complaints. So just chest pain, dyspnea. It's important that you see chest pain and difficulty in breathing also have very important differentials: myocardial infarction, aortic dissection. So it's and then of course in this COVID era, COVID is quite important. When approaching a patient with dyspnea, we did approach of a patient with difficulty in breathing, and it's on our YouTube channel. You can go on YouTube channel, Limi Hospital Network, and you will see that by the time you approach such a patient, you still have to have the back of your mind that COVID is a possibility, and then you still know that pulmonary embolism is there. If the patient is wrongly diagnosed as COVID instead of pulmonary embolism, the patient will definitely die because they've not gotten enough treatment. So what then happens to that with that blockage of the pulmonary vessel? The right ventricular failure ensues. There's an acute pressure overload to that right, and this is considered the primary cause of death in severe PE. Essentially, if you check right ventricular function in PE, that is the leading and most significant prognostic factor in pulmonary embolism, right ventricular dysfunction. If you want to know whether a patient will die or not with having a pulmonary embolism or how significant it is, one of the key factors to check is right ventricular function. Once there's evidence of right ventricular dysfunction, then prognostic indices changes significantly. Okay, so what then happens again is that pulmonary artery pressure increases, and especially if greater than 30% of the cross-sectional area of the pulmonary arterial bed is occluded by thrombi. So to overcome this, the right ventricle tries to pump, generate excess of 50 milligrams of mercury. That is not typical of the right ventricle. And then what then happens is that right heart failure comes about, cardiac collapse ensues. right wall tension increases, the wall tension begins to stretch, the wall begins to stretch, begins to try to pump against what it's not able to do. Coronary arch flow to that side of the heart becomes reduced, ischemia happens, and then, cardiopulmonary compromise occurs. Okay, so hemodynamic collapse that occurs in PE results from a combination of 3 factors. So that hemodynamic collapse that is typically a marker of very high risk PE. Once you see hemodynamic collapse, you know that this is high risk PE and you have to treat it. And there are 3 things that contribute to that pathophysiology of hemodynamic collapse, like the patient I talked about, who had hemodynamic collapse and then had to be resuscitated, had to be given anticoagulants and thrombolytics to be able to revive him. So the first is hypoxia. The hypoxia comes about, that's because of the blockage. Hypoxia on itself also stimulates vasoconstriction, okay? And then the vascular thrombus itself leads to pressure overload that alters contractile properties of right ventricular myocardium via Frank-Starling mechanism. That alteration now leads to rapid increase of right ventricular pressure and volume. While in the chronic cases, it happens slowly over time, so there's some ability for the body to adapt. In this case, it happens shortly. It causes increased wall tension. That causes the heart to try and pump more. So there's an inotropic and chronotropic stimulation, and heart failure ensues with consequent neurohormonal activation. The neurohormonal activation that occurs is what perpetuates it. So RAA system is stimulated, sympathetic system is stimulated, that perpetuates and worsens the failure. Thromboxane A2 and serotonin also are released from vasoconstriction. Vasoconstriction occurs both as a result of hypoxia and directly also, and that increases peripheral vascular resistance. The right ventricular outflow is decreased, and that further worsens the hypotension. So all these things that happen, the body is trying its best to cope. The body is trying its best to cope while it is happening. But some of these things eventually begin to become counter-regulatory, begin to worsen efforts in the long run. And so initially, the blood pressure stabilizes just by the changes in the heart. Frank-Starling mechanism happens. All of that tends to improve the blood pressure, tends to improve pulmonary blood flow and pulmonary artery pressure. However, this adaptation is limited. The right ventricle is thin-walled, it's not as thick as the left ventricle, and it cannot do this continuously over time, and respiratory failure essentially ensues. Okay, so right ventricular contraction, now the right ventricle contracts, but now its contraction now extends a little. It's trying to contract more than it's able to. That extended contraction time eats into diastolic time, and that causes a bowing of the interventricular septum into the left ventricle. So further reducing the ability of the left ventricle to cope. The next thing that also occurs now is that there's desynchronization of the ventricles. So what desynchronization of ventricles essentially means is that the right ventricle is stretched, the electrical impulse coming to the ventricles from the AV bundle to go around the ventricles, and in that process, it takes. The right and the left ventricle is not well synchronized. Okay, that now impedes left ventricular filling in early diastole and reduces cardiac output, which further worsens it. So essentially, afterload is increased, so there is a blockage that the right ventricle is pumping against. So the load after pumping, that's afterload, is increased. That now leads to the dilatation of the right ventricle. As the right ventricle is dilated, it tries to transmit that pressure across the tricuspid valve into the right atrium. The tricuspid valve is unable to hold all that pressure, so it bows to that pressure and it gives way. It becomes regurgitant. Then the right wall tension begins to increase. While the right wall tension begins to increase, what happens is that BMP is stimulated, and BMP is now released. BMP is released, and neurohormonal activation begins. Renin-angiotensin system is activated, sympathetic system is activated, and then myocardial inflammation begins to happen. The heart is pumping more than is necessary. The right ventricle with this extra pumping now needs extra oxygen. that now goes on to cause some intrapulmonary AV shunting. So just to try and bypass the places where there is blockage of the blood supply. Right ventricular ischemia happens because of mismatch. The blood supply is not matching the amount of work the heart is doing, and therefore right ventricular ischemia and hypoxic injury happens. Contractility reduces, right ventricular output reduces, which reduces left ventricular output, preload, which reduces cardiac output, which reduces systemic blood pressure, which reduces coronary perfusion, which reduces oxygen delivery, comes back here, and it just continues a difference as a vicious cycle to obstructive shock and death. Okay? So this is quite important, and this was highlighted in the 2019 ESC paper on pulmonary embolism. Also, there is thought to be some level of PE-induced myocarditis that occurs. This is thought to explain high levels of epinephrine that is found in patients with pulmonary embolism. There are also massive infiltrates of inflammatory cells in the myocardium of the right ventricle of patients who have died. So it is thought that there's some level of myocarditis that happens in addition to the ischemia, in addition to the right wall stress that happens. And then this is thought to also explain the secondary destabilization that occurs 24 to 48 hours after. Okay, so sometimes patients start getting better, then 48 hours after, they seem to get worse. So it's thought that second wave of worsening is thought to be due to this myocarditis. So what else happens? The amount of air coming in and the blood there to take the air do not match, and that is what we call a ventilation perfusion mismatch. The ventilation air coming in does not match the perfusion of blood going through. Ventilation does not match perfusion, and so that contributes to hypoxemia. So what then happens is that blood flow starts to redirect. The places, there are zones of, there are areas where there's reduced blood flow, where the blood flow is obstructed. And then the places where the blood flow is not obstructed, it tries to compensate and has overflow in those areas. And so the blood flow in that area becomes hyper compared to ventilation. So that VQ mismatch, ventilation perfusion mismatch. So we call it VQ. V for ventilation and Q for perfusion mismatch occurs. In about a third of patients, right to left shunting through a patent foramen or valley can be detected through echocardiography. And we've had a patient did not come with pulmonary embolism, came after a long flight, a young lady, 27, had been in the UK for long, after a long flight, landed in Nigeria, and came to the hospital and had a stroke while in the consulting room. Went straight, did CT, confirmed ischemic, did the echo, and saw a patent foramen ovale, which we believed could have been transmitted right from the DVT and then went into the to the left system into the brain. Okay, she's doing very fine now. No other risk factor was found except that. So all other symptoms are negative, no blood pressure, but just had stroke with a patent foramen ovale after that. Of course, we treated her, she's doing fine now, since gone back to the UK. Okay, and then so in this case, the patients that have a patent foramen ovale will now cause a shunting because the pressure in that right now shoots up very high. It now causes a shunting, and that can worsen the hypoxemia because that blood that's supposed to go to pulmonary bed does not go. It now comes directly on the body, enters back into the left ventricular circulation, and then, like I've said here, paradoxical embolization and stroke, like the patient I described, we presented in this hospital about 5 years ago. Okay, so then there's pulmonary infarction that I talked about as one of the second way the pathophysiology occurs, in which case small distal emboli will go and cause some alveolar hemorrhage. Patient will have pleuritis, will have pleurisy, so chest pain on breathing in, on laughing, will have hemoptysis and some pleural effusion. Pleural effusion in this case is usually mild, okay, and it typically does not affect hemodynamics. So patient can just come in, mild pleural effusion, some pleurisy, they are confident there's some blood in it. Not all of them is due to TB or something. It could just be pulmonary infarction that is happening. Pulmonary infarction typically happens a little bit later on, after some time, and essentially the effect on gas exchange is usually mild, except in patients with pre-existing cardiorespiratory disease. So, in view of everything I've talked about, you can now understand why right ventricular failure is the critical determinant in pulmonary embolism. It's critical. It's the critical determinant of severity and of outcome. If there is no right ventricular failure or no right ventricular dysfunction, it means that essentially that is a low risk PE. Okay, and it's very important to classify patients that come with PE as either being high risk or low risk, because that will help to determine how you will manage or how intensively you will manage such a patient. Okay, so Kaiser Permanente, that is a foreign-based healthcare organization, has an algorithm which we adopt also in Cardiocare, whereby it's not every patient that has with a PE that has to be hospitalized. And use that, I'll explain that later using the ACCP scoring system for severity. Okay, so high risk PE essentially is a situation whereby there is right ventricular failure and hemodynamic instability. Once you have a change in blood pressure, so systolic blood pressure drops by 30 meters of mercury. So if the patient was hypertensive, I was 150 and now dropped to 120 suddenly. That also qualifies. Patient has signs of right ventricular strain on echo, on ECG, that also qualifies, and that indicates a very high risk of mortality for such patients. Those that are hemodynamically unstable, they are in shock, their pulse is weak and tready, you know, they typically require emergency intervention in form of diagnostic or therapeutic nature. So it typically has to be very, very intensive. So we define the presence of hemodynamic stability is what defines a high risk pulmonary embolism. Okay, so how will you define that what other things will help determine a high risk? Number one, if patient is having a cardiac arrest. We had a patient unfortunately referred to us, had been having a DVT for long, but as she came in, suffered a cardiac arrest. So straight away, we had to resuscitate, revived her severally. Unfortunately, she did not make it. We had to intubate, ventilate, you know, try and get to the cath lab. But despite all the times we were able to revive her with CPR, was able to make it. So that is essentially one of the cases where you need to be very invasive. Okay, we tried to get into the cath lab in time, but unfortunately it was not possible. Then patients with obstructive shock, they are having systolic blood pressure less than 90, or they require vasopressors to achieve a blood pressure greater than 90 meters of mercury, you know, despite adequate filling status. And what does that mean? It means that you typically in this kind of patients, you need to monitor the central venous pressure. You can monitor the central venous pressure in two ways. In Nigeria, where it is quite difficult, in Cardiocare, we're able to put in a central venous pressure line connected to the patient monitor so that we can see the central venous pressure and determine whether the patient's filling status is okay or the patient needs an extra fluid. Okay, so we are typically able to do that with Cardiocare, but that's not always possible. If you don't have a central venous pressure line, there's a shortcut that you can use. Okay, the shortcut is to use ultrasound to assess the inferior vena cava. So if you have someone that knows how to do echo and that can look at the inferior vena cava, they can look at the inferior vena cava, and from there you can be able to kind of gauge to a small extent the central venous pressure. Just give you a rough idea about filling status of the patient. So when the patient has this and has evidence of end organ hypoperfusion, they have an altered mental status. I can see people have raised their hands. I can see some people have raised their hands, but I don't know why you raised your hands. Please, if you have a question, just put it in the question and answer box, or put it in the chat, or if you have an issue, just put it in the chat box so that we don't disrupt the lecture. Okay, or just hold on to the end of the lecture. Or if they have persistent hypotension, they have systolic blood pressure less than 90 or drop of greater than 40 meters of mercury. When that is lasting longer than 15 minutes, and you have been able to determine that it's not caused by any onset arrhythmia, hypovolemia, or sepsis, then that is reason for you to think that there is hemodynamic instability that is happening here, and you need to classify that as a high risk pulmonary embolism, which needs immediate intervention. Okay, so what are the clinical manifestations? Remember, I told you that DVT and PE are a spectrum. So you need to, one of the things that you can easily see is DVT. You can see lower limb pain and swelling. Once you are seeing DVT, you begin to increase your index of suspicion for PE. You have DVT in the lower limb, the lower extremities. It's very important for this to be checked after surgery. Okay, so patient has had a myomectomy, especially pelvic surgery, has had something, you have to begin to check some of this. Now, there are various signs that have been described. However, they are not sensitive or specific. They are just signs that you see them, you feel good as a medical, as a teacher. When I'm teaching medical students and you see this kind of signs, you're happy to explain to them. But things like Homan sign are typically not discouraged, because when you dorsiflex the ankle, you know, it causes calf pain. So what patient may tell you, however, is that they feel calf pain at the back of their calf when walking. So sometimes that may be good enough for you, and then you see that there's pain and tenderness, which will be different from intermittent claudication of peripheral arterial disease. Okay, but don't actively go and dorsiflex the ankle to demonstrate it, because in the process of doing that, you can dislodge the clots from that leg and straight to the pulmonary system. There are so many cases, and many physicians will tell you that there are so many cases of patients admitted with stroke, and they are doing physiotherapy, they finish physiotherapy, and the patient died immediately after physiotherapy. Very, very common. Or patient was about to go home, walked downstairs, as they reached downstairs, they fell down and died. Very, very common. So you don't want to be dorsiflexing that. Okay, and sometimes they have worsening pain on the leg when they cough or sneeze. They may have more pain on the affected leg after inflation. So that is Homan sign, Lovell sign, and Lowenberg sign. Okay, it's important to also just put that here, because I know some of my teachers are here. I saw some professors that registered for the webinar, so in case they are here, so that I will not fall their hand. All right, so clinical manifestations of PE. So it's very important to know that PE is very non-specific in its presentation, very, very non-specific. And by the time a patient is having PE, you know, it is typically the, what did I say? It's typically a very high index of suspicion that a doctor is able to pick it. So most times in pulmonary embolism, that's why I talked about the DVT. Although DVT is there, when patients have pulmonary embolism, most times it is because of thrombus in the pelvic system rather than the DVT. So if you have a pulmonary embolism, don't say that because there is no DVT, the patient cannot have it. More often than not, and that's why pelvic surgery is very, very high, hip surgery is very high. Don't say that because there's no DVT, it cannot be pulmonary embolism. No, because if you compare pulmonary embolism, the origin is more likely to come from the pelvis than from the lower extremities. Okay, and you know, the smaller ones will cause, you know, will cause that. Okay, so we'll go on. Dr. Abse, do you want to take your poll now before we continue?
I can't seem to be able to start it from my side.
Okay, okay. Should I start it?
Yeah, we can take the first one, sir.
Okay, so you can start it now.
Beautiful.
Check, you can start it now.
Okay, so this is the first poll talking about the pathogenesis of pulmonary embolism. Choose your most preferred answer. So it's going to show on the screen now. And I think we'll give us a full minute to answer this. You can
All right, just pick your best answer. Imagine this is MCQ for national exam, but don't worry, we'll not tell you who picked what. Just pick your best answer. Click your best answer among A, B, C, or D.
Which is most accurate about the pathophysiology of pulmonary embolism? The first alternative is that pulmonary embolism usually arises from the thrombi in the deep system of the pelvis rather than the lower extremities. The second option says that large thrombi are more likely to cause pleurisy than the smaller thrombi. And then third option, most pulmonary emboli are multiple. And then the last option says that because of the nature of the pulmonary vascular distribution, you're more likely to have upper lobe infarct than the lower lobe infarct.
Okay, let's pick. We'll soon stop.
Let's give them a few more minutes, a few more seconds rather.
Great, we are voting based on it. Simple exam, just to gauge your presence or
Okay, I think it's time to end this now. Okay, so I've ended the votings. Clearly, I think particularly based on the recent trend of the discussion now, most people picked option one. Actually, there are at least two correct answers there. The option A is correct, and the third option that most pulmonary emboli are actually multiple to is correct. But at least I'm happy that we are concentrating, and most of us learned from what the presenter mentioned now, that most pulmonary embolism are likely to occur from this proximal region rather than the distal part. So I'll just share the results now before Dr. Iseko continues his presentation. Okay, so we can see the results and now that's how we chose the answers. Large thrombi are actually more likely to cause a more dynamic trouble rather than purity. Okay, and I'm happy very few people chose this last answer as well, because most pulmonary embolism, for whatever reason, are more likely to have involved the lower aspect of the lungs. Rarely do you have those kind of impact in the upper. I mean, it's less likely to happen in the upper lobe. Okay, so that's it. Dr. Iseko.
All right, thank you very much. Thank you very much. I hope you're able to follow that. Okay, great. So I'm back to two people have raised their hands. Maybe I should take Saidu Adamu. Saidu Adamu, go ahead. Can you unmute yourself and talk before I continue? Okay. Maybe it was a mistake. All right, so let's go ahead. So PE is thought to be a masquerader. Very, very difficult to diagnose, and so you need to be on the lookout. The signs are non-specific. Patients have dyspnea, have chest pain, feel lightheaded, pre-syncope. They might just have collapsed. You know, somebody was walking somewhere, collapsed. They were in an assembly, they collapsed somewhere, you know, things like that. Hemodynamic instability is rare, but it's a very important clinical presentation, because it's typically one that shows that either the pulmonary embolus is very large, or B, that the patient's hemodynamic reserve is very low. So patient may have pre-existing heart failure or something. Now, syncope may also occur, you know, from the hemodynamic instability. And in patients that have heart failure, you know, they already have difficulty in breathing. What you may just see is worsening difficulty in breathing. So we had a patient recently, severe, you know, worsening difficulty in breathing. Unfortunately, the man hid from us that he has had DVT before, or did not make the history close, and he stopped the drugs. You know, so, you know, if not for the testing and the cath lab where we went and saw it, it would have been very difficult to treat. So, but then you just have patients with worsening dyspnea, you know, and they're not getting better on conventional treatment. You know, it's something that you need to look out for. Dyspnea may be mild if it is a small PE, or it can be severe if it is a large one. Now, chest pain is a frequent symptom of PE, and it's typically caused by pleural irritation. Sometimes there might be pleurisy even in a big one, in a big pulmonary embolism, although that's not the normal case. But that typically happens when the big clot breaks off and small clots are embolized distally, and that can now cause the chest pain. Okay, so the pain may typically have an angina character, and so it's quite important that you should keep aortic coronary syndrome and aortic dissection as important differentials. Hypoxemia happens, however, you must know that up to 40% of patients have normal SpO2. So even though hypoxemia is a very common finding, patient just has drop in SpO2, worsening breathlessness. It's also important that people know that people may still have normal. So having a normal SpO2 or SaO2 does not mean does not exclude the diagnosis, with hypocapnia also present. chest X-ray is frequently abnormal, and the utility of chest X-ray is more to help you exclude other causes of dyspnea rather than to diagnose. There are some findings that are pathognomonic on X-ray, but they rarely help you make a diagnosis of PE. So it's more to help you to exclude other causes of difficulty in breathing than to make a diagnosis. There is the standard, there is the pathognomic pattern of S1Q3, which just means that there is an S wave. So lead 1 on the ECG is predominantly negative, and on lead 3 on the ECG there's a Q wave, and T waves are embedded in the same lead. Or you might have incomplete random blind block. That is in typically severe cases. However, in other cases, you just have inversion in T waves in the right in V1 to V4, and the most common finding patients with symptoms that look like PE. In patients with suspected symptoms, unexplained tachycardia is something that may be the only point out. Pointer for PE. Okay, sorry about that. So typically, we do pretest probability scoring. It is quite very significant to do a pretest probability scoring for PE. So pretest probability scoring are very important. This is clinical. You just ask a few questions, you look at it, and you are able to make a diagnosis. Every doctor, irrespective of where you are, can do this. It is the most frequently used are Geneva and Wells scores. They are very simple. They can be done very fast, and you can use them on your phone. You should be able to download apps that have this scoring. Before you download Facebook or Instagram on your phone, make sure you have downloaded a medical app that can calculate this kind of scores. Okay. One of them that I can easily off the top of my head recommend is MD Calc, or is even there on the okay, and you can easily get that. So the most frequently used ones are Wells and Geneva, and I'll explain them very importantly. Now it's important to know that you cannot just rush to go and do a diagnostic test without this scoring system, because the pretest probability helps you to make sense out of the test. So if the patient already is unlikely to have PE from your pretest probability, you will likely be overinterpreting a diagnostic test, which is why it's very important that you do that pretest. So this is what the Geneva score system looks like. There's the original version, which is here on the left, and the simplified version, which is on the right. So essentially, if the patient has a previous PE or DVT, let's use the simplified version, you use 1. If the heart rate is greater than 95, you use 2. But if the heart rate is between 75 and 94, you give 1. Surgery or fracture in the last 1 month, 1. This is why orthopedic surgeons also are very critical in the management of PE, because a lot of the cases that will happen after surgery for orthopedics or for fractures. Okay, so then if there's hemoptysis, if there's active cancer, if there's unilateral lower limb pain, or if you can suspect DVT, that's pain on the lower limb, when you touch with unilateral edema, or age greater than 65, you give 1 for all of them. And you give 2 if the pulse rate is greater than 95. Okay, is everybody hearing me? Somebody said they can't hear me very well.
We can hear you now, sir. We've been hearing you for a bit.
Okay, so the name of the app or the website is called MD Calc. I'll put it in the chat box. I think you can easily use that to get, so it will just ask you what's the heart rate, you write it, any surgery, you just answer at the end to give you a score. Very simple. So you can easily use that in your clinical practice. No need for any highfalutin test, and that can help you to at least make some sense out of the PE or out of the PE. Okay, so when you have finished scoring it, you add all the scores, and what you do for the simplified one, you either do a dichotomized score, which just divides it into 2. If you simplify it, anything 2 and below, P is unlikely. And if it's 3 or above, P is likely. Okay, very simple. Now, you can also use the 3-level score where you can divide into low, intermediate, or high. If it is low, less 1 or below. 2 to 4 is intermediate, and then greater than 5, then is quite highly possible that you have PE. So you can easily ask any patient this one. Surgery. So let's look at. I can see Dr. Oji commented. So I remember myomectomy. You've had a myomectomy. 5 days later, the patient is a little bit breathless. You are wondering whether it is anemia or something. No, the patient has your history now tells you. In my last surgery, I had something like that. They tell you that their heart rate greater than 95. They've had surgery, of course. Now maybe they're having blood. You do not find any cancer, and then there's natural leg pain or something like that, and the patient is over than 65. Bam, you already know. If you're having a score greater than 5, it is very highly probable that you have a PE on your hands. Okay, and if you're having a 0 to 1, then it's very low, or 0 to 2 PE is quite unlikely. You cannot use the Wells score as well. The Wells score is the one that is more widely used since 1997 by Wells et al. In Lancet Journal. And that's the one I typically use more often and the one we use in Cardiocare. So if you have signs of DVT, give a score of 3. If you cannot find any other diagnosis to explain PE, that is, other diagnoses say, okay, chest infection are less likely than PE, to give 3. Heart rate greater than 100, 1.5. If there's surgery in the past 4 weeks, or immobilization 1.5. Also, you would think of things like long distance journeys may also come under immobilization, but long distance journeys are characterized by sitting in one spot greater than 6 hours. Okay, so that may not only be in the air, it could also be from Lagos to Abuja or Lagos to Maiduguri, and 2 days later they are breathless, they are coughing up blood or something. It's very important. They have malignancy or previous diagnosis, and then you now score them. Okay, so there are 2 ways of scoring also, the 3-level score and the 2-level score. If it is less than 4, is 4 and below, P is unlikely. You may just go ahead and do a D-dimer if you still need to be convinced. And then if you're greater than 4.5, then you consider doing a CT chest with pulmonary angiography. So a CT pulmonary angiography, that's CTPA. And then you have this 3-level score. So if it is very low and you still are not sure, you can go on to do another rule-out criteria called Pulmonary Embolism Rule-out Criteria, PERC. So it can be considered, or you can go ahead and do a D-dimer. D-dimer in Cardiocare, you get it in 15 minutes, so you can get a result immediately, and it can help you to a large extent. D-dimer is not diagnostic. However, it has a very high negative predictive value. What does that mean? It means that if D-dimer is normal, it is very unlikely that you have PE. However, if it is abnormal, it may be PE or maybe something else. So once you do a D-dimer less than 500, you can relax to a large extent that this is unlikely to be PE. Okay, so if you are within Abuja environs, you can just send the blood sample. You know, they get it as soon as we get the result. We'll call you with the results, and then we'll let that know. Or you refer the patient straight away, and we'll take care of the patient from there. Okay, so now we have the pulmonary embolism rule-out criteria. This is a very simple one. So if this one you are still unsure, the value is low, but in your mind you are still unsure, then you can move on to the rule-out criteria. All you are looking at the rule-out criteria is you are looking at, is there any history of any of these things? So is the age less than 50 years? If any of these things is negative, then you say otherwise. So if the age greater than 50 years, or the pulse greater than 100, or the SpO2 is less than 94, or there's unilateral leg swelling, or there's hemoptysis, or there's recent trauma, or there's history of VTO, or there's oral hormone use, straight. If any of them is positive, then you have failed to rule out PE. Simple rule-out criteria. Okay, you can have this in your consulting room, have this in your emergency room, have this in your hospital, so that you can use this when you are trying to decide what to do for a patient. So if a patient is deemed low risk, but is positive for any of the above criteria, you must do a D-dimer. That D-dimer will now help you to make progress. So, like I said about D-dimer, it has a low. You have to combine it. Okay. So if you have a low pretest probability and you have a negative D-dimer, it is very, very unlikely. In fact, studies put it as 99% is patient is unlikely to have any. So your pretest score was negative. The rule-out criteria was very, very, very low. Your pretest well score was 0 to 1 or less than 2, and then your D-dimer was now negative or low. forget it. It is very unlikely for you to be having a pulmonary embolism. Look for other reasons why that person is breathless, including COVID. Okay. Now, a positive edema helps you. It can also be elevated. Somebody that was hospitalized for a while, edema will also be elevated. Okay, so it does not also. Somebody is pregnant, edema also will be elevated. Okay, so there are some outcome studies that have been done that show that less than 1% of patients showed any problem after 3 months when you did this one. So within 3 months, there was hardly anybody that showed any problem once using this. However, there are some studies that have shown that you may need to adjust D-dimer cutoff for age. So for people greater than 75 years, the cutoff point for a positive D-dimer may need to be taken up so that you don't do unnecessary tests and put them under unnecessary stress of testing. And then clinically, if you have a patient that has any of these risk factors, that is, they have infection, they have pregnancy, they are pregnant, they have cancer, you are not sure that this elevated D-dimer, then you need to add your clinical acumen. In such a case, typically look at greater than 1,000. Typically in our center, once we're having greater than 1,000, in patients that have other reasons for an elevated D-dimer, then we take that as straight away. But if patient is already having heart failure, already having pneumonia, having other things, if you're getting 570, 600, it's very difficult for you to put that as a PE. So you may need to adjust by age and by clinical, and don't forget good old clinical acumen, and that is where you may need specialist inputs, okay? So there are tests you can do in the lab. Some of the tests are troponin, BMP, arterial blood gases. So you can get that easily done in Cardiocare. The troponin, all these tests come out within 10 minutes. So troponin is very important because it gives an indicator of right ventricular affectation. Remember we said in pathophysiology, and I said you must understand pathophysiology. We said in pathophysiology that there's some level of right ventricular wall ischemia because of the excessive pressure put on the right heart. Essentially, pulmonary embolism is a right ventricular problem. After all is said and done, yes, it's happening in the lungs, but the final thing that capitulates the whole body is from the right ventricle, from the heart. So troponin, an elevated troponin is a marker of severity. An elevated BMP is also a marker of severity. You can do the plain BMP or you can do the N-terminal pro-BMP, which is a little bit more specific. In Cardiocare, we'll do N-terminal pro-BMP and we'll use values greater than 300. When the N-terminal pro-BMP greater than 300, then, especially in patients with renal dysfunction, because renal dysfunction might cause BMP to be elevated falsely. So, patient with normal renal function, BMP elevated, troponin elevated, you're already dealing with likely a very high risk, and you need to treat it as such. Okay, so it's very important. Arterial blood gases need to be done as well. However, a normal arterial blood gas does not rule out PE, like we said earlier. Up to 40% of patients might have normal blood gas concentrations or arterial saturation of oxygen, and it still does not mean much. Okay. So I will just continue. I hope I'm not overloading everybody. So now, imaging. What now happens in imaging? We do a chest X-ray. Like I said before, chest X-ray is more helpful in establishing other diagnosis. It helps to rule out other things. What you typically find is some mild pleural effusion, some atelectasis, consolidation. Now there are some findings that are found. They are uncommon, but they can be found. Now we have quite a number of cases in Cardiocare where we actually found these classic signs. Some case reports are being written already. Westermarck sign, which is regional oligemia, Hampton's hump, you have a pleural-based wedge-shaped shadow. That is just showing you an area that has focal oligemia. Okay, and then Pala sign, which is an enlarged right inferior pulmonary artery. Okay, so let's take a short poll now. Dr. Officer, over to you.
Okay, thank you so far, Dr. Iseko. Really beautiful. Please, let's take a poll. Let's see how well we are following this. And this poll is on choosing investigations among patients with suspected pulmonary embolism. Okay, so I believe that the poll should be showing on your screen right now. The question says that in a patient whose clinical evaluation suggests a very high likelihood of pulmonary embolism, which of the following tests should be done early in ideal settings? A, D-dimer assay, C, CT pulmonary angiography, C, ventilation perfusion scan, and then D, coagulation panel. Let's see where my people are tilting. Okay, so we have a minute and a few seconds to vote. I can see that people are choosing mainly between some of the options. Okay, but let's just see how the vote goes. The patient's clinical evaluation suggests very high likelihood of pulmonary embolism. So which tests should we prioritize early in ideal setting? Okay, we'll round up the votes in a minute, in a few seconds now. Okay, we end the votes now. Okay, so this is how people voted. Most people chose CT pulmonary angiography, which is the correct answer. And some people chose D-dimer assay, which ideally, and the question says in ideal settings, which ideally for ideal settings should not be done. Actually, it was shown on one of like 4 or 5 slides away. Should not be done for patients presenting with, that shows that the pre-probability evaluation suggests a very high likelihood. And so ideally it should be a CT pulmonary angiography. But of course, in resource limited settings, sometimes you still end up doing a D-dimer first for this kind of patients. Thank you very much for highlighting that on the screen. Okay, over to you, Dr. Chapter.
Okay, thank you very much. I hope this is helpful. I'm sure using the polls, I think we should have been doing this much more. I think it's quite good. So I hope this is helpful. So the D-dimer, once your patient is already having very high likelihood, you have had your well score, straight, you should be going to CTPA. You should be going straight to CTPA, because at that point in time, such patients are typically also very high risk. The D-dimer is not going to help you at that point in time. Even if you have a negative D-dimer, you will not be acting in that direction. So it's your CTPA you should be going more for. Okay, great. Thank you very much, Dr. Alfisoye, for that. All right. So I'll continue with imaging and ECG. The major use of ECG in PE is mainly to rule out. And one of the main things, remember, we talked about is that PE comes with chest pain and dyspnea. Acute coronary syndrome also comes with chest pain and dyspnea. So that you're not rushing and trying to do D-dimer when you should be thinking about an acute MI. Now, it is critical that you have an ECG in your hospital. It is critical, I say it again, that you have an ECG in your hospital. Don't write to your CMD. If you want me to come and speak to them, if you want to write a letter on your behalf, let me know. But you must have an ECG in your hospital. In any hospital, there must be an ECG. It is, I don't want to say anything, but it's critical that you must have an ECG. And so use the ECG essentially to rule out major diagnosis. The most specific finding is S1QT, but we don't find it more often. Most times we just find what I talked about, atrial dysrhythmia, right bundle branch block, sinus tachycardia. On echo, what we find are all the things we talked about during the pathophysiology. We find a TR, we find when the right ventricle is dilated, the septum is flattening because the right ventricular pressure is not pushing it. Sometimes it is even moving into the left ventricle. We have diastolic dysfunction, pulmonary arterial hypertension, and then the inferior vena cava fails to collapse on inspiration. So when we take a deep breath or a sniff, the inferior vena cava narrows a little. So it narrows up to about 50%. So in this kind of case, you don't see that, and that tells you that pressures are quite high. And rarely, sometimes you might visualize the thrombus directly. There's a sign called McConnell sign on echo, and it essentially is that you have right ventricular fluid hypokinesis, but the apex is spared. And the specificity is quite high, 94%, and it said that this can help in discriminating whether the right ventricular dysfunction you are seeing is due to PE or other causes. If you are seeing it, then you are almost very sure that this is due to PE. So it has a positive predictive value of 71%. Okay, and once you are seeing hemodynamic collapse in a patient you are suspecting for PE, definitely you should right ventricular dysfunction. So if you don't find right ventricular dysfunction on echocardiography and there's hemodynamic collapse, then you need to reconsider your diagnosis. Of course, maybe echo will be able to help you at that point. Ventricular perfusion scanning is very rare in Nigeria, but it's also something that is being done, and we're yet to start it in Cardiocare as well. But it's something is considered a second-line imaging method. It typically is quite useful, especially in people that have a normal chest X-ray, or in people who are able to undergo CT scan. It's quite something that you can use in its place. At the end of VQ scanning, what happens is that it gives you a result as high probability, intermediate, or low probability. So those that the VQ scan is especially helpful when it is normal or it's a high probability. The ones that have intermediate or low probability, which are the most common finding, you still have to make sure that your pretest probability was high, your D-dimer was high, then you now have intermediate, then you can now say, okay, it is now PE. Now, CT has become the standard imaging technique for diagnosis of acute PE. CT-PA, you can see the thrombus directly. You can exclude other diseases like aortic dissection, pneumonia, including COVID, you can see straight away. And sometimes you can do CT venography of the abdomen and pelvis to view the veins in case you can see that. Of course, CT is costly, but everything is costly generally. And then, of course, you are exposing to radiation, which you are able to do in pregnant women. Okay, so if you have a low pretest, I've talked about this one before, so I will not go about this. So now I'll just explain this algorithm to everybody. This is an algorithm for an adult person. So let's say a non-pregnant woman with man or woman without cancer. This is the algorithm that we will use. Okay, and essentially, let's start here. So I hope that is a little bit clear. Great, so that's bigger now. So essentially, we start here. You see the patient, let's say an outpatient or inpatient with suspected pulmonary embolism based on symptoms. The first question you ask yourself is the patient clinically unstable? If yes, you do a CT straight. You don't even have to start controlling D-dimer, just like we talked about, especially clinically unstable with all the criteria and positive testing. If no, do your well score. Well scores greater than 7, CT-PA, but start your anticoagulation while you are waiting for all those kind of things. If it is less than 4, then it is less likely. And so you will go straight to the pulmonary embolism rule-out criteria like I've talked about. If it is negative, it's unlikely, consider that diagnosis. If it is positive or you're able to do it, do your D-dimer. And I said you should adjust your D-dimer with age so that you get the best results, okay? And negative D-dimer is unlikely. Positive D-dimer, go to CT angio. CT angio is negative, okay? And if it's positive, start treatment. But at this point, you need to determine the treatment setting, whether you want to do ICU, ward, or you want to do home management, depending on how the case is. And I'll explain that in a jiffy. Okay, so if you have a negative or a non-diagnosis, let's assume the well score was 5 or 6, and you went straight to your CT-PA. In this case, it is thought that you should still go back and consider again. Now go back and check your D-dimer. So if you ask me in our resource poor environment, D-dimer is also expensive, CT is expensive, but life is more expensive. You should do both, okay? Especially when the score is between 5 and 6. So if it's negative, do your D-dimer. If your D-dimer shows that P is likely, do your lower limb Doppler ultrasound. And if that is positive, treat for venous embolism. Okay, so it means that if your CT is positive, if your CT is negative, despite a high well score, what you likely have is a DVT and not a PE. And if it is positive, you have a PE. So if it's negative, do your D-dimer. Your D-dimer is positive, go and look for that DVT in the lower limb or the pelvis and treat. If D-dimer is negative, it's unlikely, go and do something else, you know, and treat. And remember the well score that we talked about. Okay. Okay, so that is what you do. For pregnant women, this is how you will approach pregnant women presenting with this. So you suspect it, you check clinically unstable. If it's unstable, you go to CT pulmonary angio and go like we talked about in the last one. No, you check are there leg symptoms. If there are leg symptoms, do a lower limb ultrasound. Remember, for them now, you have to be thinking about the baby as well. If CT-PA is contraindicated, you can consider a VQ scan. But remember that if you're going to do CTPA, you have to shield the abdomen. Okay, and remember the patient is clinically unstable, and if you do nothing, death is likely. So at this point in time, very high risk, you are going to prioritize the woman's life in that kind of situation. So, and if no, clinical picture is stable, but you check leg symptoms. So we had a lot of cases from the gynecology unit where we had this kind of dilemma we looked at. Check for leg symptoms. If there are no leg symptoms, then consider chest X-ray or CTPA. If there are leg symptoms, do your ultrasound. Ultrasound is negative here, and if it's positive, treat as pulmonary embolism. But in a pregnant woman, there is no option for any other treatment. It must be inpatient treatment because you have to monitor the baby and determine whether you need to deliver or not, depending on gestational age and other things. Okay. So if chest X-ray and are still negative, P is unlikely, other diagnosis should be considered. And if it is positive, treat for PE. You have to think of other diagnoses that occur. Pneumonia, pneumothorax, heart failure could also occur. One patient that we're evaluating for PE in Cardiocare, pregnant woman, about 28 weeks or 30 weeks, I don't know if Dr. Officer remembers, eventually on her echo, so went in the process of this, we also did an echo. In the echo, we found a congenital heart disease. I can't remember what congenital disease it was, either a PDA or an ASD. I think an ASD that was there, and you know, that's what we found at that point in time. Okay, I think my sound went off and it's back. So, and that's what we found. So in the process, we now found something else, you know, that could, you know, complicate, and that was how we treated her, but I think she delivered very well. So if the patient has cancer, however, do the well score. Typically, the well score already be high because of the cancer and everything. If the well score greater than 5, go straight for your CTPA. If it's less than 4, do chest X-ray and D-dimer. Okay, but remember that the D-dimer here, because D-dimer already be elevated in people with cancer for other reasons. So you need to interpret that cautiously. Otherwise, if it's yes, no, if the D-dimer is negative, do your CTPA and then treat accordingly. So that's for adults with cancer. So I think that's a quite straightforward treatment approach. Okay, so American College of Chest Physicians consider that some patients can be managed for as outpatients. However, I will in Nigeria, and everybody, most of the people on this webinar are Nigerians. I will not advise outpatient treatment because patients may not be compliant, next they just come back dead, or patients may not be well enough. Patients go home and they say they should drink one thing or the other, they go and add other things to their therapy, worsens everything. So I will not suggest that. But if you are running out of bed space, you have other issues, you're in a village and you have other issues, you should also consider this. You should consider the pulmonary embolism severity score, whether they are compliant, and you must make sure that the patient has no sign of severity. Okay, so we use this one also, this pulmonary embolism severity index, use it to check, and it's a validated score, easy to use, to no cost. You can use it to determine how severe the pulmonary embolism is. If it is less than 65, low risk. 66 to 85, you know, less than 65, very low. This one, intermediate. If it is greater than 106, high risk, and greater than 125, very high risk. For those with higher and very high risk, you should really consider ICU care. And if intermediate risk, you might still manage otherwise. So how do we treat? So I'm trying to hurry up to try and, because we have Dr. Olaleko is standing by to talk about the anticoagulation options that we have, especially those with the newer agents. Okay, so standard of care in management of PE essentially is 3 forms. I want us to remember this. If you don't remember anything, standard of care in this is anticoagulation, number 1, then followed by so anticoagulation with heparin, Clexane, or fondaparinux. Then fondaparinux is not very available, Clexane is available, heparin is available, followed by warfarin, that's vitamin K analogs, or the newer agents. I tend not to favor warfarin in cardiocare practice. We tend not to favor in cardiocare. We typically prefer the newer agents for several reasons. Number 1, monitoring. And patients have a tendency to just disappear. So they are taking warfarin, you know, it's quite difficult. So except you have a very highly motivated patient, or you have a situation such like, just like a valvular lesion where NOACs are contraindicated, they will not have to use warfarin. But if all the patients really cannot afford it, then you not use warfarin. Otherwise, then of course supportive care, oxygen, ventilation, fluid management. This is the standard of care. These three things will be done concurrently while still managing whatever underlying condition is there. Okay. Now, thrombolysis is one of the possibilities that has been done. A lot of patients do well just using these three. So thrombolysis is reserved only for hemodynamically unstable patients with massive PE and those with a low risk of bleeding, because you don't want to give thrombolysis and cause a stroke and even kill the patient in the end. That could have been done well just with anticoagulation, just Clexane or dabigatran or rivaroxaban. So if patient does not need it, so we have had a patient we had to admit in the ICU, an elderly woman about 68, I think all the other consultants will remember. We thrombolized here in Cardiocare, in ICU, hemodynamically unstable, dyspnea unexplained, chest X-ray typical, CTPA, D-dimer massively elevated, greater than 2,000, you know, and straight away ICU, not getting better, requiring inotropic. Once we thrombolized, they could not afford the conventional thrombolysis, which we prefer, which is RTPA, a tenected place, typically altered place. So we had to use streptokinase. Once we thrombolized, I'm telling you, before long, blood pressure, everything started normalizing, SpO2 started normalizing. And we tried to have him in 3 days after. Unclear whether there's any benefits. So this is the whether there's any benefit for thrombolytic therapy for those who are stable and have but have right ventricular dysfunction. So we have a gray area. The patient has right ventricular dysfunction, but they are stable. Whether to use thrombolytic therapy or not, and this is where you have to call for a specialist to weigh the benefits versus the risks. Okay. There's also a treatment called catheter-directed thrombolysis. In this case, there has been only one reported case done by our interventional cardiologist, one of our interventional cardiologists in Nigeria, and Dr. Edafe. He published the paper in January 2019. It's available free on the internet. Dr. Edafe is one of our interventional cardiologists, and during the procedure, sorry, Dr. Officer, you're speaking. Okay, so Dr. Edafe reported that during the procedure, what happened was SpO2, while on table, started rising and rose from 76% to 97%. Pulmonary artery pressure dropped to 48 millimeters of mercury while on table. No complication. Patient was discharged 4 days after. SpO2 remained 47 to 97 to 100%. But this was in a patient with a massive pulmonary embolism. Remember that we say that such things must be reserved for such patients. This is the case that was done by Dr. Edafe, who is one of our interventional cardiologists in Cardiocare. And you look at the ECG, you can see the T-wave inversion there. Let me point it out. You can see the T-wave inversion in V1, V2, and V3 with some ST depression right there in V1, V2, V3. Okay, and this was published in the International Journal. And this is the CT, and you can see the feeding defect. So you can see these areas where the arrows are pointing at with a little dark areas on the right. Those are the feeding defects, and you can see it here as well. Okay, and so this is the catheter. This is the catheter there is in the pulmonary artery during the catheter-directed thrombolysis, and the telomerase wire was passed in so that the thrombus can be macerated, and that's what we do. We pass the wire into to macerate the thrombus, and then you can this telomerase wire has been replaced. If facilities are available, you can use an ultrasonic catheter. You pass an ultrasonic catheter, and the ultrasonic catheter essentially will send an ultrasonic shock wave to kind of just break up the clot a little bit. And then you instill your outer place or connected place directly in that region. So in that case, you're using a very small dose and you have less risk of bleeding, systemic bleeding, okay? And so there's only been one case documented in Nigeria done, and that was a fantastic outcome that happened, okay? And that was published in January last year. So embolectomy is also done. Surgeons go in and try and remove the emboli, you know. There have been no randomized controlled trials concerning this. and typically it is in patients who have a contraindication to thrombolysis or may not be able to do the catheter-related thing. These are some tests that you need to do while preparing, while trying to go ahead with your testing. Okay, so why you want to start your therapy? So full blood count, essentially, it will help you look for things that may also give a reason why the patient is having it. Also, full blood count later, use of heparin can cause thrombocytopenia. So it's important to look at that. APTT in antiphospholipid syndrome, and then CKD is quite important because you will know what drugs not to use and how to adjust the doses of your drugs in case of any of the drugs you are using. So it's quite important. You may need to do an INR to establish your baseline before starting any warfarin or anything like that. Okay, so these are the medications options that are available. Typically, warfarin can be used in general adult population, but I told that our preference is typically for the newer agents, although they are typically quite expensive. You can use low molecular weight heparin, that's Clexane. If there are contraindications to warfarin and to this one, you can just use the Clexane. Especially pregnant women, this can be a very good option. It's very difficult to use warfarin because of the both of them, because of the side effects, on the baby in terms of teratogenicity. Okay, so but warfarin you have to overlap it with heparin while giving it. So we have to get it. The recording will be on YouTube. So immediately after this, if you log in with your same login details, you may be able to get the recording on Zoom. We'll also we'll send you the link for the recording via email. We'll also send you the link for Dr. Issa, good to see you, consultant cardiologist. Nasara, great to see you here. Okay, so we'll also send you the links so that you can rewatch the recording. Other recordings are also there for previous webinars that we have done: chest pain, difficulty in breathing, COVID and pregnancy. We've done quite a number of things, so you can go there and watch them and rewatch them, including neonatal things for pediatric cardiology and in pediatrics. So these are the ways to think about it. Rivaroxaban sometimes is considered to be preferred, especially because of ease of taking it, number one, and number two. And why it is also preferred sometimes is because you don't have to overlap with warfarin. While dabigatran, you need to overlap with Clexane or with heparin. Rivaroxaban, you can start almost immediately, and then twice a day for 21 days and once daily, so it becomes a once daily drug. Both of them are quite expensive, I must tell you, so it's not something that is very easy for patients if they don't have any insurance or they are not able to afford it. Okay? So, warfarin, if you are starting the dose 2.5 milligrams, 5 milligrams initial dose, sorry, this is a mistake. 5 milligrams initial dose in people that warfarin density, or 2.5, you may even go down as low as 2.5. So you are not sure some patients whether they will just get a very high INR immediately. Remember that warfarin is, if you start warfarin, initially you start warfarin increases the likelihood of coagulation of clots. So that is why you must overlap it. And warfarin does not start acting until about 5 days, 3 to 5 days. So you must be giving heparin, either low molecular weight or together with it, or normal heparin or fractionated heparin. And in patients, you start with 10 milligrams, 2 doses, then you bring down to 5 milligrams after the 3rd day thereafter. Okay? Concurrent with low molecular weight heparin, you must do consecutive INR tests to get between 2 and 3 so that you will know that you are getting this. Okay? You can use Clexane, and Clexane 1 milligrams per kg every 12 hours is fine. So typically you can do something like 80 milligrams twice a day, or 60-60 or 60-40. That is typically about 120 milligrams a day that you use for that. Now, instead of warfarin regimen, which rivaroxaban can also be used, or dabigatran. If it's rivaroxaban you are using, don't use them together, of course. I'm just saying either or. Rivaroxaban, you can start it immediately without any need to overlap, and there's not much to check. So you can start it almost immediately, especially for those that you think you can manage outpatient. But typically, the patient is having a diagnosis of PE, and you are sure you have gone through the ACCP and you have specialist inputs. You can now consider short admission, maybe 12, 24 hours, on Clexane or warfarin before starting on this and letting go. What was I saying? So dabigatran. Now the other novel oral anticoagulants, and apixaban is one of them. That's Eliquis. Okay, I have one patient on it. It's not very common in Nigeria, and it's also very expensive. Rivaroxaban and dabigatran are around the same price range. Okay, so how long will you treat a patient? Typically a minimum of 3 months. I typically advise that you go up to 6 months, especially, and then some patients may need to go up to 12 months or indefinitely, and that depends on what happened or on their bleeding risk. So what was the cause of the PE and what was their bleeding risk? That will help you determine and whether there's a risk of recurrence for that. So you check the bleeding risk factors. Is there active bleeding? Do they have an acquired bleeding disorder? Are their platelets low? If they've had lumbar puncture, all these ones are things that will help you. They have had a stroke, you know, you might have to adjust if they are more likely to fall, you might have to adjust your anticoagulation lower down. Okay, so we determine whether it is a provoked or an unprovoked PE. A provoked PE is when there's a known event, patient had surgery and developed PE, nothing else. You can
Okay, so we'll try to increase the space a bit now so we can finish on time.
pregnant women. Now, of course, remember that warfarin will affect the baby. NOACs have not been really tried in children or breastfeeding mothers, so you may have to use Clexane throughout that period, which is a real challenge. Okay, so patients, just like insulin, patients have to learn how to give it. Unfortunately, in Nigeria, the dose for that is quite expensive. So oxygen may need to be administered whenever the SpO2 is less than 90%, and if there is respiratory failure and the oxygen and is refractory to oxygen therapy, you should begin to consider a right to left shunt that is happening either for impatient foramen normally or an ASD, and you need to check for it actively while you're doing an echo. Mechanical ventilation might be needed in extreme cases, and patients with high susceptibility, patients with right ventricular failure, you need to be aware that if they have right ventricular failure and are hypotensive, when you are intubating, and anesthesiologists need to know about this, when you are intubating or trying to do any surgery, imagine you want to do any surgery on that kind of patient, the hypotension typically worsens and is typically very severe. So you need to be very, very careful. Even with positive pressure ventilation, it typically worsens hypotension. Now, if you are correcting fluid, so patient comes hypotension, not breathing well, somebody just hypotension, let's rush fluid, bam, that normally is a problem. If you load fluid too much in these patients, you will over-distend that right ventricle that's already trying to suffer, and that will further reduce the cardiac output, which is not good. So you need to be sure that diagnosis, you have to take your time, why is this person having, and you might just have a modest fluid challenge, and then you assess your central venous pressure by your catheter and your monitor, or if you're looking at the vena cava. Prophylaxis is very important. In all these patients that have risk factors, either they have thrombophilia, and the patients that have a greater risk, you've admitted a patient that you think is going to spend more than 2 days on admission for any reason, and the patient is immobilized, has an MI, stroke, pneumonia, diabetes, is over 40 years, they are obese, you know, you should definitely consider giving them anticoagulation. Of course, the high-risk surgeries, especially hip surgeries, knee surgeries, especially needs anticoagulation prophylactically there. Now, there are two major forms of prophylaxis that you must consider, mechanical and pharmacologic. Mechanical is the use of whereby you are using compression stockings, pneumatic compression devices. So you can use a normal TED stocking, TED stocking, but the prevention of DVT by TED stockings is very low. It's considered to be less than 10% protection. So just by putting TED stockings, you're not getting the best. And that TED stocking must be tight and must be tie high to even give you that 4 to 10% protection. It's typically about 4%. So, but if you can get a pneumatic compression device, you put it across the calf and it sequentially compresses the legs, and that gives a much higher, then of course you can use heparin, you can use rivaroxaban. Rivaroxaban, a lot of surgeons find it very useful. You can use warfarin as prophylaxis, especially if the patient is going to be immobilized for a long period. And then you can use dabigatran also for prophylaxis. In high-risk population, those with knee and hip replacement, you can combine both mechanisms of mechanical and pharmacologic therapies to prevent VT. Is very important. So, and then there are some patients that you consider extended prophylaxis for thromboembolism. I'll leave Dr. Olalekan to talk about that briefly before we go. In those, especially those for hip surgery, remember I told you that the pelvis is one of the ones that throws the most. So you might consider extensive prophylaxis. These are references that I've used for this presentation. Thank you very much for joining us today. We are going to have short, what do you call it? Short presentation.
Yeah. Thank you so much, Dr. Iseko, for the beautiful presentation. It is very, very, very insightful. And even me at this level, I'm taking a lot away from this, and I would like to review this video again later. So we'll take the questions and answers after briefly, but briefly now, Dr. Olalekan, consultant cardiologist, would be presenting just briefly on one of the new anticoagulant agents that has a role in the treatment of pulmonary thromboembolism and also even in the prevention. So, Dr. Olalekan, are you there, sir? So this will be as brief.
Hello?
Yes, go ahead. You can share your screen. I saw your screen just a moment.
Okay.
Share your screen so that we can see it. We'll try and be brief. So just hang in there. He's about to go into the meat of
my screen now.
No, I'm not seeing your screen. Try and share your screen again. It came off and went off.
It's showing. I can see the screen.
Okay.
Oh, okay.
Is it here now?
Yes.
Yes.
Okay. Okay, so quickly, I'm Olalekan, consultant cardiologist. I will just be going through the non-vitamin K antagonist anticoagulant, the NOACs. As my colleague has talked about most of the things I have in my introduction. So we just go straight into the middle of the matter, the anticoagulant. As he mentioned, we have the parenteral, the heparin, low molecular weight heparin, and the other anticoagulants, the vitamin K antagonist, the warfarin, and the main one that we're talking about, the NOACs, the factor 10A inhibitors, the rivaroxaban, apixaban, and the factor 2A inhibitor, the dabigatran. And then the disadvantage of the traditional anticoagulants, he mentioned some, the need that you have to give injection, frequent need for monitoring, adjustments and interaction with food, and difficulty in patients with renal diseases. And going to NOAC gives us advantage over all these traditional anticoagulants in that you have a drug that you can simply give once or twice daily. There is no need for monitoring. There is no need for food interaction. Don't eat this, don't eat that. And it has superior, in some cases, superior efficacy and similar risk compared to your warfarin and your enoxaparin. And apart from pulmonary embolism and DVT, other indications for use of these new agents, including prevention of stroke in patients with atrial fibrillation, especially those with non-valvular atrial fibrillation. Then in some patients with cancer, you can use this to prevent thrombosis, and for DVT prophylaxis after knee and hip surgery, like my colleague mentioned before. And yeah, a typical example I'll be using today is the rivaroxaban, the Xareto. Like I said, it's a factor 10A inhibitor. It has a predictable therapeutic effect. It is not affected by age. It's fixed dose, rapid action with half-life stated between 7 to 14 hours. And like we said, there is no need for overlap. You can start the patient on it directly. You don't need to use warfarin. You don't need to use enoxaparin before you take your patients to this drug. And in patients with atrial fibrillation, according to the Rocket studies, which compare the use of rivaroxaban 20 milligram daily with warfarin in patients with non-valvular atrial fibrillation with CHART score greater than 2. In this study, most of the patients have advanced I score and they have advanced risk factor for development of stroke. It was found that rivaroxaban is not inferior to warfarin in the prevention of venous thromboembolism. There was actually a 21% reduction in risks for patients that were on rivaroxaban compared to warfarin. And looking at the safety analysis, it was found that major critical and fatal bleeding were even less in patients on rivaroxaban compared with warfarin. So critical bleeding in critical sites like intracerebral bleeding and bleeding in other critical areas were even less in patients using rivaroxaban compared to patients on enoxaparin. So the study concluded that rivaroxaban is less inferior and with similar safety profile in patients with atrial fibrillation, and it is advisable that you can use your patients. Then looking at patients with deep venous thrombosis, patients with pulmonary embolism, the XSTEM program look at patients with DVT without PE, patients with PE without DVT, and they look at use of rivaroxaban, 15 milligram twice daily for the first 3 weeks, then 20 milligram daily thereafter, and compare it with enoxaparin. And at the end of the study, they found that rivaroxaban compares favorably and is not inferior to patients that use enoxaparin and warfarin. And like I said, they even found out that there was less fatal bleeding, reduction by almost 50% in patients with pulmonary embolism that were taking rivaroxaban. So more efficacy and less bleeding side effects. And for those that needed extended use of anticoagulants to prevent VTE recurrences, it was also found that using rivaroxaban in the XSTEM extended study, also compared to placebo, showed 82% risk reduction in the recurrence of venous thromboembolism, because it is found that once you stop your anticoagulation after the acute treatment, patients, especially those with unprovoked pulmonary embolism where you don't have an triggering event, has about 10% risk in the first year of developing another venous thromboembolic event. So giving these patients extended anticoagulants reduce this risk to a significant effect. And in the extended studies, it was found out that rivaroxaban gives almost 82% relative reduction and with similar safety results when compared with placebo. And also talking about preventing recurrence of venous thromboembolism, the fear is balancing the risk of bleeding and prevention of venous thromboembolism. And in the XSTEM choice study, rivaroxaban was compared with aspirin in these patients, because people have the fear of, okay, if we use this for a long time, patients are prone to development of bleeding. But when rivaroxaban 20 milligram once daily, 10 milligram once daily was compared to aspirin of 100 milligram, and given to patients who completed acute treatment for a period of 6 to 12 months and not given extended treatment for 1 year, they found out that rivaroxaban reduced the risk of recurrence compared to aspirin, whether you use the 10 milligram dose or the 20 milligram dose of the patient. So the reduction in VT recurrence is small in patients taking rivaroxaban compared with those that use aspirin. And the safety profile was similar. The major risk across the group was similar, about 0.5%. So whether in acute treatment of pulmonary embolism, deep venous thrombosis, and in long-term prevention of venous thromboembolic events, use of factor 10A inhibitor shows non-inferior and similar or even better safety profile in terms of bleeding when compared to either aspirin or compared to enoxaparin with warfarin. And in patients with cancer, like the first speaker said, the risk of development of venous VTE and major bleeding is higher in patients with cancer, whether they are on enoxaparin or heparin. And when they were tried on rivaroxaban, it was found that rivaroxaban reduced the recurrence of VTE in patients with cancer, and also the risk of bleeding when compared to low molecular weight heparin and warfarin is almost similar. And it was found that use of factor 10A inhibitor actually reduced the risk of fatal bleeding in patients with cancer, except for patients with gastrointestinal cancer, because it was found that factor 10A inhibitor gives more of gastrointestinal bleeding. So it should be avoided in that class of patients. And the International Society for Thrombosis and Hemostasis actually recommend the use of factor 10A inhibitor in patients with cancer that are not gastrointestinal and with low risk of bleeding compared to the use of low molecular weight heparin. And we've talked a lot about orthopedic patients with hip replacement and knee replacement. The record triad actually showed that patients on this group on the factor 10A inhibitor performed very well with reduction in the total venous thromboembolic events and with similar bleeding when compared to low molecular weight heparin and vitamin K. So these patients can safely be given any of these factor 10A inhibitor for prevention of DVT in this group of patients going for this surgery, whether for acute use or even over the 5 weeks period, especially in patients undergoing hip surgery. And dosage, like we've mentioned, for acute treatment of VT and pulmonary embolism, we give 50 milligram BD for the first 3 weeks. Then you follow up, then you continue 20 milligram daily, depending on the duration, the risk factor, whether 3 months, 6 months, or for those that need extended treatment based on the risk of having recurrence of DVT. And like I said, there's no need for monitoring. There is no need for interaction with food. And if you want to switch your patients that are already on warfarin to rivaroxaban, what you need to do is stop the warfarin and start rivaroxaban once patient has an INR between 2 and 3. For those on enoxaparin and heparin, what you do is stop the infusion, then 2 hours or the next dose of the warfarin of the enoxaparin, you start your rivaroxaban. That is what you do for enoxaparin to rivaroxaban. And this is also the same slide if you want to go from rivaroxaban back to parenteral drugs. For those going to surgery, stop your rivaroxaban or other factor 10A inhibitor 24 hours before the procedure. And after the procedure, once adequate hemostasis is established, you can recommence your medication. In patients with renal impairment, you can safely give your rivaroxaban from 30 creatinine clearance of 30 ml and above. For those below that, you have to use with caution and adjust your dosage and weigh the risk against the benefits. With hepatic impairment, you avoid use in patients with advanced liver disease. It is not recommended that you give your patient with prosthetic heart valve factor 10A inhibitor, same way in pregnant patients and in patients and lactating patients. Like the first speaker said, patients with hemodynamic instability, the first thing to do is to thrombolize before you start start your parenteral anticoagulant. Then once the patient is stable, can take orally, you can safely switch them to the factor 10A inhibitor. For now, there is no routine lab test that can detect overdose of this factor 10A. That is one of the small let-off that we have for now. And you can try some of these measures. It's non-digestible, so you can give activated charcoal and some of this newer antidote that is being tried. So in conclusion, you have the NOACs. It's convenient to use. You can give orally, you don't need to overlap. Fix dose, less interaction. You don't need to monitor, and there is reduced risk of major bleed in critical areas. So when you're considering giving your patients, you can consider this and weigh the benefit to the patients. And like the first speaker said, issue of the cost, insurance, and maybe availability in some area. But overall, it's been shown that it has the same efficacy and with less critical bleeding in most of the area. Thank you for listening, and we await your question. Thank you very much.
Thank you very much, Dr. Alelkan, for the succinct presentation on rivaroxaban as a Xarelto. So we will take questions and answers. We'll answer some of the questions that are asked live now before the PR representative give some further comments on the pharmaceutical aspect of things. Okay. So the first question here says that it's not a complete question, unfortunately. The diagnostic test for pulmonary embolism in our environment, considering the cost. So I assume that the person means that what diagnostic tests should we favor in our environment, considering the costs?
I think that question was asked before we started the presentation. So,
oh, yeah, that's true.
So by the time you look at it in light of the presentation, you see that you can do well score, which is cheap, which doesn't really cost anything. After you have done the well score, you have to determine whether it's very highly likely or very highly unlikely. By the time you think the patient is very highly likely of having a PE, if you don't have a CT or you don't have a CT-PA near you, at least you're going to do a chest X-ray and ECG, and you should start treating empirically. If you have the ability to do the tests, but I don't want us to get used to doing the wrong things. Generally, I'm sure near you there will be some center that can do it very well. So you should consider getting full diagnosis. The reason why you need to get a full diagnosis is because the patient there's a significant risk of bleeding from PE, from the drugs. And they are going to give anticoagulants for a minimum of 3 to 6 months. You don't want to put anybody on that for that long with all that risk without even being 100% sure of that diagnosis. So it's quite important. So you have that index of suspicion, start your anticoagulation, and then go ahead and at least you have the dimer or something, or refer the patient to somewhere else. Thank you.
Sorry, I was mute. The next question says that what does OR of greater than 10 mean? I think that's odds ratio. I'm not sure what slide that was referring to.
Odds ratio. So it means
so
it's more
odds
likely.
Ratio greater than 10. Okay. So the next question here says that patients with COVID-19 typically exhibit the phenomenon of silent hypoxia and raised D-dimers and sudden deterioration followed by death. How can one avoid a misdiagnosis of COVID-19 as PE, thereby leading to unwarranted treatment and exposure for all? Basically, how can we distinguish between the hypoxia, raised D-dimer, and deterioration that COVID-19 presents compared to similar thing that can happen in a patient with pulmonary embolism? What do you think, Dr. Iseko?
Okay, so I wanted to add some slides on COVID-19 and pulmonary embolism, but the presentation was getting too long, so I just left it out. Okay, so I want everybody to take in mind that you should assume that every patient has COVID-19 in this era. So start with that assumption and protect yourself while you are going ahead with the assessment. Now, it's also important to know that D-dimer and troponins will also be elevated in COVID-19, especially patients that have a more severe disease or presenting late. Okay, so that's also possible. Number 3 is that pulmonary embolism can complicate COVID-19. Besides being a differential diagnosis, it could also coexist, either complicating COVID-19 or COVID-19 could complicate patients with pulmonary embolism. So patients could have pulmonary embolism and have COVID as well. So all of those need to be put in mind. So how to avoid the diagnosis of COVID-19? The only way to avoid misdiagnosis is to make sure that you do all the tests. Do your well score, do your this thing. It's unlikely that COVID-19 will give you a very high well score. In any case, do your D-dimer and then do the COVID test. If you do all of them at the same time, you should be able to at least exclude or include. Now, if the patient has COVID, that does not exclude the patient from having, from having PE. And in all the criteria, not all the criteria, at least the international, I'm not so sure about Nigeria's own protocol. The national criteria has standard dosing for anticoagulation. So once somebody is diagnosed with COVID, they typically should start anticoagulation, especially if they have moderate to severe disease. So they start anticoagulation as prevention, and also you start treating while you not start investigating. If you think the patient has the thing, you need to do your CTPA, you need to do everything as at when you.
Okay, sir. Let me quickly add that the presence of COVID is not an indication for use of anticoagulants. But if patient has COVID and other indication that warrants use of anticoagulants, it should be given. And patient that are already on prophylaxis for DVT, even if they have COVID, should not stop if there is no contraindication.
Yeah, great. That's very great. Well, there are some guidelines, however, that try to include it, especially for those that have diabetes. You know, those that have diabetes, heart failure, you know, all those that we say have high risk. So they consider giving what they call it prophylactic doses even before the diagnosis. I think in Egypt, in the UK, rivaroxaban, some of them have been indicated, but not as a treatment for COVID. I know there was something that went around WhatsApp saying that COVID is a embolic disease. Yeah, possible, and I think the risk factors are you know, the more severe cases also have kind of cardiovascular phenomena. So definitely something to consider. Maybe we should allow Mr. Gideon to do a brief presentation before we continue. He has exactly 3 minutes. Mr. Gideon, you have 3 minutes.
Yeah. Hello, everyone. Can you hear me?
Any questions? If you have any questions for Mr. Gideon as well, please also add them while we are answering the questions.
Hello, am I audible?
Very audible.
Okay. Good evening, everyone. Thank you so much for honoring our invite. I'm trying to share my screen. Yeah, thank you for honoring our invite. Is my screen visible to everyone?
Yes.
Yes.
Okay, good. Okay, good. Yeah, so as I was saying, my name is Gideon. I am the buyer representative for Xarelto, and I'm resident in Abuja, and I cover some states in the north too. Thank you very much, Dr. Iseko, for the insightful presentation. I actually learned a lot. I, at a point, started feeling like a doctor. Thank you so much, Dr. Olaleye, for shedding light on Xarelto, which is our fantastic brand of oral anticoagulant. I wouldn't like to talk about things that have been said, so I would just be shortly discussing on the home treatment of patients with low risk pulmonary embolism with the oral factor 10A inhibitor rivaroxaban, which our Xarelto is actually the innovator brand. At this point, I would like to say that Xarelto, we are in Bayer, we are patient-centric. And of course, when it comes to Xarelto, we try to ensure that our brand of rivaroxaban is safe and has high efficacy for our patients. So we've actually done a lot of studies, phase 3, phase 4 studies, even real life studies, just to make sure that our product is as safe as studies and reports say it is. I would quickly like to talk on the benefits of home treatment of low-risk pulmonary embolism for our patients. The first one is actually reduce pressure on patients and even healthcare resources. I mean, in these days of COVID, that we are trying to, of course, reduce the amount of patients in the hospital at a time. It's always important to make sure that as much patients that can undergo their treatment from home actually get it that way if they don't have any high risk of recurrence of pulmonary embolism. So it's actually an advantage to the patients and also to the healthcare resources. Also, there is low risk hospital acquired conditions. You know, when patients stay for a long time in the hospital, they tend to develop other conditions. With Xarelto, after 2 days, we always say the patient can go home and, of course, continue with the use of Xarelto. There is no need for monitoring, so the patient doesn't even need to be bothered about monitoring. It is the patient doesn't need to get injected. It is not injectable. It is an oral formulation. So it's actually even more comfortable for the patient to do that from home. And at the end of the day, the patients are actually happier because one, it's taken once daily for that's after the period of high risk. It is taken once daily, so they don't even really need to be bothered about the multiple dosing. Compliance is increased. I would like to talk on quickly discuss the study that was done. We call it the HOT-PE. It is actually a single-armed prospective phase 4 study. And the aim of the study was to show that Xarelto is a feasible, effective, and safe drug when it comes to the treatment and prevention of pulmonary embolism. This is more of an overview of the study. 525 patients were enrolled into the study, and they started them with the 15 milligram twice daily dosing of Xarelto, which it is taken twice daily because, of course, the first 21 days is usually the high risk period. So we always want to ensure that there is no emergency case within that period. So Xarelto is usually used 15 milligram twice daily for the first 3 weeks, after which it can be continued with the 20 milligram dose, which is taken once daily for 3 months. Of course, some patients, depending on the risk, depending on comorbidities, might take for as much as 6 months. But for the case of this study, it was actually done within 3 months. So, of course, some patients were also placed on 50 milligram once daily. Those are the ones with creatinine clearance less than 30 milligram per minute. I saw somewhere in Dr. Iseko's slide that rivaroxaban cannot be used in those category of patients. However, Dr. Olaleye clarified that. I would also like to shed just little light on it. It can actually be used in those patients with creatinine clearance less than 30 mils per meal. However, we don't encourage its use once the creatinine clearance is less than 50 milligram per meal. So yes, it can actually be used. So to the results of the study, this is actually a graph showing the percentage of patients versus recurrent VT, recurrent PE, recurrent DVT, and death-related pulmonary embolism. As it can see, for all these things I've mentioned, we have less than 1% of patients who come out with either recurrent DVT or recurrent PE, recurrent VT, or death-related pulmonary embolism. And as it is seen on the slide, the recurrent DVT and death-related PE is actually 0%. No patient was recorded to have those two. However, for recurrent VT and recurrent PE, 0.6% of those patients, I mean 0.6% of 525 patients is actually very, very low. That's less than 2-3 patients or so. And the major bleeding is 1.2% in those category of patients, which is very, very significant. Dr. Olaleye mentioned that, of course, in Einstein choice, Einstein DVT, it compared with enoxaparin, and it was seen that Xarelto was actually non-inferior, which is actually very good. And it was also seen in the same study that Xarelto has high safety and efficacy and reduction in bleeding and other things, other conditions that could arise from ineffective anticoagulation. So basically, the rationale is that the rationale behind treating our patients from home after like 1 or 2 days, if they are low risk, of course. I know that Dr. Iseko mentioned earlier that high-risk patients are usually characterized by RV failure, and they are usually hemodynamic unstable, like there is high hemodynamic instability. So these are for the low-risk patients that we know that, okay, they don't have what the conditions I just mentioned. The chances of having reoccurrence is low, and we've considered every other parameter. Those patients can be discharged after the second day. The point of it is that there is reduced health cost for those patients, and also the patients are more satisfied. Even the burden on the doctor, healthcare workers, and others is reduced. Despite this, it was actually seen that only 6% of patients with stable PE are treated from home. Most of them are usually still treated from the hospital. I want to assure all of us that, I mean, with Xarelto, it can be started from day one. There is no need for injectable enoxaparin or any injectable as seen with most other NOACs. With Xarelto, it can be started from day one, and it can be continued all through. This alone would improve patient satisfaction. Also, previous clinical trials investigating home treatment of pulmonary embolism have used different definition of low risk, and well, they were carried out in the pre-NOAC era. That's before the NOAC came. Unlike VKAs, Xarelto is actually available as oral single drug regimen with no need for parenteral bridging, like I mentioned, and single dosing after the first 21 days, no need for monitoring, very reduced side effect. But we always try to encourage doctors to encourage patients to ensure to get the registered Xarelto, because with the registered Xarelto, there is guarantee of efficacy, there is guarantee of safety. So we always advise them that they should try as much as they can to get the one with the NAFDAC register number, because anyone that doesn't have the NAFDAC register number, there is no guarantee. If there is any issue and it is not that, it can be taken up by our medical management, basically. So we should always try to encourage our patients to get the registered Xarelto. Quickly, I would talk about the dosing. Like as I mentioned, it's usually 50 milligram BD. That's for treatment of DVT, pulmonary embolism. It's usually started with 50 milligram BD. That's twice daily, and after the 21 days, that's from day 22. we always advise that, of course, after risk assessment and all that, that the patient should take Xarelto 20 milligram once daily. However, in patients, as I mentioned, in patients that have creatinine clearance less than 30 milligram per mil, they can reduce, they can do a dosage adjustment from 20 milligram to 15 milligram. They start 15 milligram BD. When it's time to continue from day 22, they can take 15 milligram once daily instead of the 20 milligram. Then after, depending on the duration, after different assessments, if the patient is to take Xarelto for a longer period than 6 months, we always advise that it can either be taken 10 milligram if the risk is very, very low, or 20 milligram if there is a high chance of VT reoccurrence, or maybe additional comorbidities and all that. If we have any questions, any complaints, issues, clarification needed, the email address is here. The first one is for our medical. You can contact them. You will get a swift response. If there is any adverse reaction that has been gotten from the use of Xarelto, we always advise that you can send a direct message or contact me. You can send the message to that email address on the screen, or you can contact me directly. Those are my numbers, which you can contact me. Also, before before ending my presentation, I would like to address a concern that I know Dr. Iseko hammered on, which is actually the prices of NOACs. Well, I actually hear the complaint, and to be honest, we've also been trying to see how we can make things more convenient for our patients. I can say that recently we've actually reduced our price of Xarelto, and compared to the available NOACs and even injectable enoxaparin, I can say that Xarelto is far, far low when it comes to pricing. If we compare dose per day, I mean 1 tablet of Xarelto versus a dose per day of either injectable enoxaparin or dabigatran, Xarelto in Nigeria that is readily available now to our patients is actually far lower. You can hold me to my words. And also we are partnering with M-Pharma, which I am aware that Limi does business with them. If, of course, if...
Okay, we'll need to round up now. So there are some questions that are still outstanding, but obviously I don't seem to be able to see the questions again. Maybe I did something wrong.
Okay, I'll go through some of them in the chat. First of all, some of the one in the chat box before I go to the one in the question and answer segment. Okay. So one of the ones there asked if sickle cell disease was that was asked by a consultant physician actually, if it's an established risk factor for venous thromboembolism. And the answer to that is that hemolytic anemia is generally a risk factor for venous thromboembolism. We should remember that in sickle cell disease, they often have thrombocytosis, and then the amount of inflammation that they have increases their risk for thrombus formation. And this risk is actually higher in ST than SS. So especially during a crisis, there's a risk for thromboembolism, especially in people with sickle cell disease that are older. Any extra comments to that, Dr. Iseko?
No, I totally agree.
Okay, I'll just scroll to the questions to see if there's any other key thing that is missing on this. Yes, to be attended to. Okay, so somebody asked, Mr. Job Otokola asked that CTPA is expensive. That's CT pulmonary angiography is expensive and not readily accessible in many hospitals in Nigeria, which is true. Can bedside echocardiography be enough, especially if we use it to assess the right side of the heart and making a judgment on pulmonary embolism? What do you think? Okay, so an answer to that question is that the changes, the echo changes that we see in pulmonary embolism usually will be seen in the severe cases. So in the mild and moderate cases, usually we may not get anything on echocardiography. And if a patient has hemodynamic compromise that we expect or that we think was due to pulmonary embolism, If we see a normal echo, it can be reassuring that it's likely not pulmonary embolism. But in patients with likely mild and moderate PE, a normal echo does not say much, because in most of those people, the echocardiography will be normal. And those people, even though they may appear low risk at that time, if that mild or moderate pulmonary embolism is not treated, they can soon even go on to have a severe one that can give them hemodynamic disturbances. So an echo is useful in the absence of CT pulmonary angiography. An echo is useful in combination with things like D-dimer and ECG to make a decision. But as much as possible, if we really suspect it and we don't have any clear cuts, especially if we are thinking not to treat, it's better to have a very reassuring CT pulmonary angiography. Someone wrote here that thromboembolic deterrent stockings are not effective, like Dr. Iseko mentioned earlier. They're not really effective. So why not SCD? I'm not sure what this is, SCD. And then any discussion on intravascular filter. So of course, there's a role on intravascular filter, particularly in people with deep venous thrombosis that are at risk of PE or that have had some PE before, but they are not suitable. They have contraindications to anticoagulation. So for example, now let's say a patient has deep venous thrombosis and has an hemorrhagic stroke or some other key contraindications to anticoagulation. Or some of them are even simply intolerance of anticoagulation. Either they are reacting to it or they have other issues with it. Such kind of patients are candidates for the intravenous cover filter, which will just trap the clots, will not reduce stop the clots from forming, but will prevent them from going to the lungs. Now, Dr. Chidima Jijalaya asks that what diagnostic test is preferable in pregnant women, CT pulmonary angiography or ventilation perfusion scan, considering the radiological exposure? This is a common question, and the risk in doing either of these two tests for a pregnant woman, we're talking about the risk to the baby and the risk to the mother. So doing a CTPA, okay, so doing both increases the risk of the mother for breast cancer and increases the risk of the fetus for things like leukemia and other childhood cancers, okay? So CTPA poses a higher risk for the mother, whereas a VQ scan poses a higher risk for the baby. And usually the decision is just made between who you are willing to put at more risk. But usually, even in well-developed countries, we should put this in mind that a very large proportion of VQ scans come out to be indeterminate, and you still end up needing to do a CT pulmonary angiography for such people. But usually, I think it's best to follow the algorithm that Dr. Iseko used, in which, as much as possible, we're able to avoid doing either of these two tests. But if it comes down to it that you have to do one of the two tests, then we should know that a CTPA increases a woman's risk of having future breast cancer, and that's because the engorged breast traps the contrast that is used in CTPA very highly, and slightly, the absolute increment in risk is very, very little, okay? And also that the VQ scan increases the risk of childhood cancer for the fetus if the woman has a VQ scan. But I'll tell you that most people opt to do a CTPA in pregnancy if we are forced to do one of these investigations for a pregnant woman. Dr. Alima Olalere asks that what do we give a bleeding patient in puerperium that has a deep venous thrombosis? That's a slightly difficult question, and I'll tell you that what needs to be done for such a patient is that we should wait until that bleeding is controlled before you give anticoagulants. Usually, if you immobilize such a person, the risk of embolization of that clot is really limited. So usually, if you can get that bleeding under control within 24 hours, usually you can wait for that before you start your anticoagulation. Okay, but in more very sophisticated center, if you have everything at your disposal, some people will choose to give such a person an inferior vena cava filter to trap the clot so that it just doesn't go to the lung. But I'll tell you that in practice, in this kind of environment, you are probably better off waiting until that bleeding is controlled. Once we're talking about a DVT here, we're not talking about a pulmonary embolism. Wait until that bleeding is controlled. Usually, a person bleeding in the puerperium, usually you don't expect that serious bleeding to last for more than 24 or maximum 48 hours. Now, the residual bleeding that is just like every menstrual flow is not really a concern. So that one will not be worsened. And of course, usually we are better off with agents like the newer oral anticoagulant agent or the fractionated, the Plexane air rather than something like warfarin or unfractionated heparin.
All I'll just add is that once you have that kind of case, remember that it is multidisciplinary. That case already poses a multidisciplinary setup. So you need to get in the hematologist, the obstetrician, the cardiologist, the pulmonologist, all together on that kind of case, so that the obstetricians are doing what is necessary to control the bleeding. I will say, depending on the case and how much the risk is of PE and how high the risk is, in some cases you might take care of them both concurrently, just by giving a lower dose of anticoagulation, because the anticoagulation may not depend on how you're able to control the bleeding or not. So I think it's something that has to be taken on a case-by-case basis. And once you have such a situation, you definitely need specialist input, and you need everybody or all hands on deck. Now, if it is PE you're talking about, you definitely have to find a way to balance it out, because you cannot just leave the person without it, especially if they are a high-risk PE, like we talked about, they have hemodynamic compromise, they have other things. You need to get them to be on ICU, you need to check central venous pressure status for anything, and you are able to use echo, a very high score on Wells or whatever on Geneva, and then you have a suggestive ECG, you have suggesting everything, and then you did echo and show electrical dysfunction. You can start treating without a CTPA, using all of this as a concrete means of diagnosis. However, if your Wells score, Geneva score are indeterminate or very low, and your D-dimer is neither here nor there or slightly elevated, you may not have enough reason to put that patient on it, and there you have to just depend on clinical skills. It will be like treating somebody in the dark. So as much as possible, try to get necessary things you need to work to be able to make a better decision. Yes, any other questions?
Thank you, Dr. Iseko. Someone asked that we should explain what the S1, Q3, and T3 means on the ECG. And I have an ECG I will use to just try to demonstrate that. So if we look at the lead one, where's my highlight now?
Your screen is showing.
Okay, if you look at the lead one on this ECG, you can see that the S wave is prominent. It's quite deep. So the first positive deflection is the R wave, and the next negative deflection is the S wave. I'm not sure that my mouse is showing. Anyway, so you can see that there's a deep S wave in lead one, and if you go to lead 3, you can see that even though it's a tiny Q here, you can see that there's some extent of Q in this lead 3, and there's an inverted T wave in lead 3. So that is actually what makes the S1, Q3, T3 pattern. Of course, we should know that this is not common. I'm not sure what fraction of patients with pulmonary embolism will have this, but it's probably less than 25% of patients with pulmonary embolism that will have this classic pattern. So, but this is actually what it typically looks like. Chief, any additional comments to that?
Okay, so I'll just add here that you should also note the T wave inversion in V1 to V4, in this case almost up to V5. That is likely, you will see that more common than the S1, Q3 pattern. So if you see this kind of T wave inversion in somebody with breathlessness, you should very strongly consider the person, especially if you have an elevated D-dimer, you should very strongly that person is having a PE. And then of course, this patient is very tachycardic. This heart rate is about 120. So it's also one of the very, very common things that you'll find in patients with PE. Those are some of the things you should look out for besides just the S1, Q3. That one is good though, but it's not very, very common. Either should you wait for it to make a diagnosis. T wave inversion V1 to V4, very important. V1 to V3, very important. T wave inversion V3, AVF, also very important. And then in that lead one, if it is equiphasic or you have an S wave bigger than normal, then you now consider it very strongly.
Thank you, Dr. Iseko. Someone asked that can PET stockings, that's thromboembolic deterrent stockings, we use in a suspected DVT. Can it dislodge the clot? Yes, any manipulation of the leg can dislodge the clot in DVT, but usually in DVT, actually, stockings are recommended. So if you just be worn carefully. The reason why it's recommended is it slightly discourages propagation of the clot, that's one. And then additionally to that, it reduces the occurrence of post-phlebitic venous trouble problems, either things like varicose veins, venous insufficiency are reduced if the person wore test stocking while treating the DVT. Of course, test stocking is not the primary treatment for the DVT. No, the primary treatment is anticoagulant, but it can be used in patients with DVT, test stockings.
What I would just say is that try and start the anticoagulation before
you wear it. Okay.
Wear this test stocking, so that the anticoagulation will reduce the likelihood of propagation of the clot. You don't want to be wearing test stockings, so a nurse that you are not there is wearing test stockings, and boom, the patient becomes breathless and dies. So you really want to start something first before you now go on to that. Okay,
some people ask for the recording on the YouTube. The recording will be on YouTube on that Limi Hospital's network channels. Hopefully, we'll send the link as soon as it's uploaded there. That should be within the next 48 hours or so. Thank you, Dr. Isa, for your comments on organ cardiologists. For those on warfarin, counseling on food and other items that interact with the drug is key. And that especially the herbal drugs, which often contains ginseng and all those things. So that's very important, and that's one of the very limiting problems with the vitamin K antagonists like warfarin. There's a lot of food restriction, and if we have to place a patient on them, they should be well counseled on the dietary changes and the limitations that they have to make. Okay, and he has had a good experience with use of unfractionated heparin on patients with massive PE. That's good. That's good. So it's important to always anticoagulate patients with massive pulmonary embolism. Any patient with any form of pulmonary embolism should be anticoagulated, actually. Either whichever agent you choose to use, there must be anticoagulation there. And of course, the ones that need thrombolytics usually should be made to get that. Someone's experience is that many old deep venous thrombosis patients are still on warfarin from the doctors in the UK. What's the role of INR in this condition? Yes, the truth is that, especially in the UK, which is a very conservative country, they're actually just switching more and more people to the new anticoagulant agent. So compared to many parts of the world, the UK is still using a lot of warfarin, okay? And it's because they've invested a lot in the infrastructure to monitor warfarin. So they've actually distributed a lot of INR meters, just like glucometers, for many patients on warfarin. So you couldn't have invested that much and now just want to change overnight to the newer agent. So part of the reason for that is economic, and because they have a very solid system in place. They have anticoagulation, they have warfarin clinics, okay? So of course, the role of INR in treating in patients on warfarin is you use it to adjust the dosage of the drugs initially. Number one is that during the overlap period between either warfarin or either clexane or heparin, during the overlap period, you want to make sure that your INR gets to target before you discontinue the parenteral agent. So usually when you're starting warfarin, you start together with heparin, and then you continue the heparin usually to about day 3 or 5. But of course, at that time, you want to make sure that your INR is within range before. And of course, for monitoring, usually because of the way warfarin does, particularly its interaction with diet, you need to monitor the INR to make sure that the patient is not overcoagulated. Because the patient can just decide to eat a certain food item and then the INR just jumps to this, and you want to be able to really monitor that. Otherwise, if the patient spends most time out of therapeutic range, you may not be anticoagulating the patient well. Dr. Michael asked about the role of Dacron grafts in preventing pulmonary venous embolism. It talks about Laplace law, which comes into play in that, and that emphasis should be on clotting factor, not only on clotting factor, but on all the components of vacuous triad. And also that mutation of the mutations that are related to PCOS, that's polycystic ovarian syndrome, of certain proteins will also predispose some patients to AV thrombosis, including pulmonary venous embolism. Thank you very much, Dr. Michael Kolawole. We've been experiencing, someone says they've been experiencing a lot of treatment failures with Xarelto. What could be responsible for that? Well, I won't be able to really answer that, but what I'll say is that, of course, Nigeria, quick tablets can be an issue sometimes, one. And then secondly, of course, is how we define the treatment failure. I will remind us that the fact that a patient is on anticoagulation does not zero the risk of having clotting issues or thromboembolism. Okay, it can still happen, it's just that the risk is really, really reduced. That's one. And then secondly, we should remember that in patients with established thrombotic event or thrombotic issue, what the anticoagulant does is to reduce or limit the propagation of such clots or stop the propagation of such clots. It doesn't lyse it. Okay, so we should just put those in mind when we are defining something like treatment failure. What I can say is that compared to agents like heparin and warfarin, particularly warfarin, in which a lot of things can interfere and the dose that each individual needs is quite variable. For the newer agents, those issues are not there and monitoring is not recommended. The reason why monitoring is not recommended is that usually it's a given that if your patient is using the medication in the right dose, coagulation clotting is limited. Someone asked why rivaroxaban is not used in non-valvular AF.
Okay, so essentially the reason is that not just rivaroxaban, dabigatran, and the novel oral anticoagulants. The reason is simple: studies. So by the time the drugs were being introduced, they are compared against warfarin. And in patients with valvular AF, they were found to have worse outcomes. So they were found to be as effective and even more effective in comparison to warfarin for other cases. But in that subgroup analysis of patients that had valvular heart disease, especially mechanical valves and all that, they seem to have worse outcomes. And so based on that, I'm not so sure about pharmacology or whether they were able to find the reason why, but that was the finding after multiple studies, and so it's generally not advised. So if somebody has valvular AF or valvular or mechanical valves, they are not advised to use any of the NOACs, rivaroxaban, dabigatran, apixaban. Then you have to stick with your warfarin and then manage the patient very closely, monitoring the INR and all of that.
Okay. Dr. Ebuka asks, a patient that are low risk and are successfully treated for pulmonary embolism, how long do we continue the anticoagulant for? And under what grounds do we stop? That's a very good question.
I think we answered that some slides towards the end of my presentation. The patients that are low risk, when they has PE, you are treating, I said there are two things we consider, whether it is provoked or unprovoked, A, and B, whether it is a recurrent cause, and number 3, whether the person has a risk for bleeding. So that is what will help you to determine whether how long you should treat. Irrespective of whatever the reason, the patient must be treated for at least 3 to 6 months. If it is a low risk and the patient has a malignancy, you must treat indefinitely. If it is a pregnant woman, you will treat for at least 3 months, of which 6 weeks it must extend 6 weeks postpartum. And if it's an adult without cancer that is not pregnant, then you should consider 3 to 6 months and determine based on the risk of bleeding. I will say we determine the risk of bleeding whether they are propensity to fall, whether they have concurrent other illnesses, whether they have to take concurrent other drugs that may interfere, and then you now determine how long you stay. So 3 to 6 months for people that are low risk, having no issues, should be considered for them if they have a venous embolism.
Thank you, Dr. Iseko. Thank you, Dr. Isa, for mentioning that, for reminding us that the heart history is important, particularly looking at when we're suspecting that a patient has a pulmonary thromboembolism. By the time we're looking for the S1Q3 T3 pattern, we're looking for the T-wave infarction in the right-sided list that Dr. Iseko showed us. We should also put in mind that right axis deviation too can be suggestive. Thank you very much, Dr. Isa.
Okay, I think we have run out of time, so we'll have to stop here. Thank you everyone for joining up. We are very happy to share from Cardiocare. Cardiocare is in Abuja, in Gariki Area 11. These are the phone numbers. This is what our facility looks like. This is the waiting area for patients when they have procedures. We have a cath lab where we unblock arteries. We also are able to fix the interfere vena cava filter for patients that qualify. Although we've not had any case yet, but we're able to fix we use the cath lab. We also measure the pressures. The catheter-directed thrombolysis that we talked about is also done in the cath lab. So we insert the catheter straight into the pulmonary vessel, and then we now, using wires like this, patient is awake almost throughout. Using wires like this, we now pass it through and get there to the heart, and then now give a smaller dose that will reduce the risk of bleeding. And then patients that have heart attack, this is like patients that had a heart attack that we did the angio for, and then opened up the blood vessel. And sometimes we also do devices. This is for a patient with a CRT device. Okay, so you will get also details of the next presentation in your mail. We will try and group all the CME so that we don't give 1 point or 1.5 points. So at the end of a month or at the end of maybe 2 months, we give one CME certificate that covers as many lectures as you're able to cover as possible. Just join up. If you have any questions, further questions that have not been answered, you can send to cardiocaresymposia@gmail.com. And then on YouTube, just search for Limi Hospitals Network. You see you see it there. You will get an email from us also afterwards with the link for rewatching this webinar so that you can get on. You can watch it again, and then also share it with your facility and have them learn from the thing that we have done here. We will be likely going our next topic, likely either next week Friday or upper Friday, will be atrial fibrillation diagnosis and management. If it changes, you'll get that information in your emails as well since you're registered. Thank you all very much. Okay, sorry for those that had problems joining up on Zoom. Well, we don't control Zoom, we just subscribe to it. Thank you all very much. If there are any final questions, we'll take them, but I think we can stop here. Dr. Xray, over to you. Any issues?
No. Thank you very much, everybody, for joining us. It's been wonderful having you. Forgive us slightly for eating a bit into your time. We'll always keep on working to keep it as precise and as concise as possible. And thank you, Dr. Iseko. The presentation was very wonderful, sir.
Thank you very much, Dr. Iseko. Thank you very much, Dr.
Thank you
very much, Dr. Lale.
So we'll hope to do this again sometime. I can see a lot of people that joined up, different professors, different cardiologists, consultants all over the country. This was more or less our highest attendance ever. We had quite a number of people here. I think
good to hear that.
Yeah, great.
Good to hear that.
All right.
Thank you very much.
Thank you very much.